Thank you guys. It's great to kick this off. And so I'll be talking about the neovascular AMD pipeline. These are my financial disclosures. This is a really robust pipeline. It's a very exciting time to be in Retina. We have so much in the pipeline that 10 minutes doesn't even scratch the surface. So I've kind of picked three things that are interesting to me that I'm going to focus on after giving you guys an overview that are not being covered by Kat and Rishi. And so first, we started this whole journey with extracellular VEGF pathways, right? We have multiple VEGF-A inhibitors that we utilize, such as ranibizumab, bevacizumab off-label, pegaptinib in the past, and then came aflibercept. Aflibercept also blocks VEGF-B and placental growth factor. More recently, we've seen high dose aflibercept come to the market. In ex-US, we have combercept. Now, VEGF-C and D, there is a product by Opthea called OPT-302, and we're learning more and more about the importance of VEGF-C and D, and I'm going to cover that in detail in just a moment. The integrin receptors are transmembrane receptors also that connect the extracellular matrix to cytoplasm. And there are several companies that look at the integrins, including Allegro, Algenesis, and Asclepics. And I'm going to cover in detail Asclepics product AXT107 in just a moment. And then you have Tie2 receptors. More recently, we've seen the approval of faricimab, which is a bispecific antibody that blocks VEGF-A along with Ang2. But there are other companies looking at Tie2 activation pathways, including Boehringer Ingelheim, Revopsis, Affimed, and AppPro. And so a lot of activity in this area. Gene therapy is really something that's fascinating to me. I think that's the wave of the future. Several companies looking at gene therapy. Kat's going to give an amazing talk, I know, on gene therapy in just a moment, and so I'm not going to get into that. And then Rishi's going to talk about tyrosine kinase inhibition. You see how many companies are looking at TKIs, right? Multiple companies, and so that's an area where pan-VEGF inhibition is possible, and with different modalities. These pathways don't fall into any specific category, so we're going to call them other pathways, right? And so there's several of them. The mechanisms of actions are intriguing. The one that I'm going to focus on today is by Unity Biotechnology, which is a senolytic, and so we'll talk about what that is. So kicking off with OPT-302 combination therapy, there's mounting evidence that targeting just VEGF-A is an incomplete therapeutic strategy, right? And the research has identified the role of VEGF-C and D in wet AMD, DR, and DME. And so it turns out that we've looked at preclinical models. VEGF-C stimulates retinal angiogenesis, as shown in the panel on the left. In the center panel, which is a mouse model of wet AMD, we see that you can actually decrease the CNVM with either monotherapy with OPT-302 or with aflibercept monotherapy, but the combination of the two gives you a synergistic effect with even better results. Interestingly, if you inhibit VEGF-A, like with bevacizumab, for example, you actually get an upregulation in VEGF-C, and so again implicating the role of VEGF-C in this disease state. So OPT-302 is a trap inhibitor. We've seen other traps, right? We've seen aflibercept, and this is very similar in terms of its ocular biodistribution and PK to aflibercept, and it's a potent inhibitor of VEGF-C and D. And instead of VEGF receptors 1 and 2, we have VEGF receptor 3 that forms the fusion protein that has combined them with a fragment of the human IgG. And so it's used in combination, so it's not a standalone product. You use it in combination with the VEGF-A, so you have either ranibizumab or aflibercept, and then you pair that with OPT-302, and then the combination completely blocks VEGF receptor 2 and 3, and these are the most important pathways in angiogenesis and vascular leakage. The data is actually quite compelling and provocative, I'd say. This is a phase 2b trial, and you can see in this 2b trial is 24 weeks. At the end of the trial, you can see that there is actual visual acuity superiority. Now, there's not many slides you're going to see today that show you visual acuity superiority, so this is very interesting data that we saw at 24 weeks. This was the OPT-302 high dose combined with ranibizumab compared to ranibizumab sham, 3.4 letter superiority. When you looked further at a subset of patients with occult and minimally classic lesions, this group actually had a 5.7 letter difference in superiority. And these types of patients represent about 75% of wet AMD patients, those patients with minimally classic and occult lesions. So next is the phase 3 trials, the SHORE and COAST trials. COAST is already completely enrolled. SHORE is almost there. These are treatment-naive wet AMD patients that will be randomized or have been randomized to either ranibizumab and OPT-302 or aflibercept and OPT-302 with OPT-302 dosed at every 4 or 8 weeks. And so we look forward to seeing these results mid-2025. The next product I'm going to talk about is UBX phase 2 Envision study. It's a 24-week study looking at senolytic cells. So senescence occurs during various disease states like macular degeneration or diabetes, and the retinal vasculature is affected as an upregulation of cytokines resulting in these disease states and blurry vision. If you can provide a senolytic, i.e. remove these senescent cells, and you can potentially repair these vessels and restore vision. And so this is kind of the premise here: cellular stress, aging, diabetes causing accumulation of these senescent cells, and then ultimately diseased tissue. You add a senolytic and you clear these cells, and you have regeneration and restoration of function. So one main player in this process is BCL-XL. BCL-XL is a protein that inhibits apoptosis. And so this keeps these senescent cells alive. And so if you look at this control mouse retina on the upper left panel, you can see staining for green BCL-XL, not a whole lot there. You look at the diseased diabetic mouse, there's more in the way of BCL-XL, showing the role here of BCL-XL. And you also see it on the bottom right panel where neovascularization is present. You can provide an anti-BCL-XL, which is UBX 1325. To these, in this mouse model, you can provide this, and you can see decrease in inflammation. You see decreased IL-1B and IL-6 and TNF when this is provided, and vascular permeability is also decreased in this preclinical model. In human data, we have a phase 2 Envision study looking at patients with wet AMD. In this trial, patients with treatment-exposed AMD, at least 4, on average had 4 injections in the last 6 months, were screened and provided aflibercept at baseline, and then randomized to receive either UBX 1325, dosed at 0 and 4 weeks, and then again at 24 and 28 weeks, or aflibercept that was dosed every 8 weeks for the first 24 weeks, and then at 24 weeks we added UBX 1325, so it's a combination treatment at that point. Here we'll show you first here the results for the aflibercept group. So they had a surprising increase in vision of about 3 letters at 2 weeks. And so this was maintained through 48 weeks. And so this was a surprise. The vision was maintained. The UBX group did well. They maintained vision at the end of 48 weeks. They were 1.5 letters down. But because the aflibercept group gained so much vision, the UBX did not meet its non-inferiority margin for vision, though it did demonstrate biological activity and durability. It was well tolerated in terms of its safety profile. And the key takeaways here are that 40% of UBX 1325 treated patients did not require anti-VEGF treatment through 48 weeks, and 64% achieved an anti-VEGF treatment-free interval over 24 weeks. Finally, I'm going to talk about AXT107. Okay, so we're going through these fast, but we only had 10 minutes. AXT107 is a first-in-class integrin regulator, and it actually has 3 mechanisms of action, so it's like a tri-specific. It inhibits neovascularization. It does this by binding alpha V beta 3, which then dissociates from VEGF receptor 2 and destabilizes it, resulting in an inhibition of neovascularization. It can also bind alpha 5 beta 1, and the beta 1 dissociates, and you see this clustering of the Tie2 there in the center, and that really changes the game because Ang2, which was previously a bad actor, becomes a good actor and can activate Tie2. And then finally, it can suppress vascular inflammation. It does this by upregulating I kappa beta alpha and then inhibiting NF kappa beta. And this is very early stage, so we have preclinical data, and the preclinical data shows on the left they're well-formed endothelial cell junctions, the goal. Then you could put these endothelial cells in culture, and you can see that you can add AXT107 in increasing concentrations, and you see initially on the left of that jagged irregular VE cadherin. And as you go to the right and you have increasing doses of AXT107, you see co-localized actin and VE cadherin at the cell-cell junctions, looking more like the ideal picture on the left. Here you can see suppression of inflammation. You can see that when there's no TNF alpha, the NF kappa beta is in the cytoplasm. When you add TNF alpha, it goes into the nucleus. But in the presence of AXT107, the NF kappa beta stays in the cytoplasm. So you're suppressing inflammation. You also see reduction on the right in those graphs of inflammatory cytokines like VCAM1 or ICAM1. In the rabbit, there is a model here for vascular edema, and you can see fluorescein leakage at day 30 is reduced in both AXT107 and aflibercept compared to control. At day 60, the aflibercept is back to the levels of the control, but the AXT-107 remains reduced, demonstrating durability. And so finally, there is a phase 1/2a in-human study called Discover that's ongoing currently. This will be AXT-107 delivered in a suprachoroidal fashion, and we look forward to the results. It's a dose escalation trial. So there you go. This is an exciting time to be in Retina. Lots of products in the pipeline, and who knows, in 10 years we'll be much like oncologists. We'll have lots of products to choose from, and we'll have to make the right decision for our patients. Thank you all.
Great presentation. Any questions for Dilsher? Anybody on the panel?
One of the questions that I had is so many of these exciting therapies that you mentioned have a slightly different mechanism than like we're used to, like combination, or they're given in different ways. How are we going to decide how to use different therapies for different patients? And do you foresee insurance making it more difficult for us to be able to
Yeah, absolutely. Payers are going to play a big role in this, right? But I mean, in the absence of payers, I see, every new molecule that comes out, we always think about what's the value add here. Up until now, we've looked at durability, the drying ability are the two key value adds. I mean, anything that can make vision improve is going to stand alone, I think. So I'm really excited about that. But in general, I think durability and the ability to dry are two big ones.
Awesome. Thank you.
Thank you. Next up, we have Dr. Talcott, and she's going to talk about gene therapy for neovascular AMD and GA, another topic easily covered in 10 minutes.
It's like speed dating. All right, so I'm going to be talking about gene therapy. Here are my disclosures. So I'm just going to provide a sort of an overview of gene therapy overall. Obviously, there's a lot of stuff in the pipeline in this mode of sort of coming up with treatments. I'm not going to hit everything, but I'm going to kind of provide a bird level view on gene therapy. So we're really fortunate, as Dilsher mentioned, to have lots of intravitreal agents that we can use for neovascular AMD, including the ones listed there. And these have been shown to be very effective at improving vision in randomized clinical trials. However, when we look at real-world studies, these illustrate that sometimes long-term outcomes are difficult to achieve. As you can see in sort of the 5-year data from CAD, although patients had visual gain at 2 years, these were lost, unfortunately, by 5 years. And part of the reason for this is that we undertreat patients, in part because, frequent treatments are a big burden to patients, their caregivers, and to us, as well as, we don't treat as often as they do in studies. So really, I think there's an opportunity here for innovation. So can you come up with a sustained way to be able to make sure that anti-VEGF is around? And can this help to be able to address injection burden and undertreatment? Similarly, in the area of GA, we're so fortunate to have treatment now available, but the treatment that's available really still requires patients to get injections every month or two. So gene therapy, I think, provides an interesting innovation as a way to sort of address this. It really prompts the eye to make a novel therapeutic protein or overexpress normal proteins. So really coaxing the eye to become sort of a biofactory. And for AMD, at least, unlike IRD, which I'll talk about a little bit later, these are applied in a way that's ignoring what someone's gene defect is. So rather than treating one target, these sort of just look at more sort of end-stage pathways to be able to address it. And this might be able to really help address that injection burden problem. It's possible that one can imagine that you can have a therapy that you can have sort of one and done. So I'm just going to be providing sort of a brief overview of gene therapy, first looking at neovascular AMD. I'm first going to start off by talking about RGX-314, which is an AAV-based gene therapy, which is designed to deliver a gene encoding for an anti-VEGF Fab protein. The phase 1/2a study was recently published in Lancet, looking at 42 patients, and when this was delivered underneath the retina, it showed sustained vision gains and stable anatomy over time. And if you looked at the individual cohorts of those patients who were getting sort of the higher doses, in cohort 4, they actually saw a reduction of almost 60% in terms of the burden of people getting injections, and in cohort 5, it was over 80%. There's different ways that it's being looked at how to give a patient gene therapy. So I talked about putting it underneath the retina. Another attractive option is using the suprachoroidal space as well. This is treatment that could be given in clinic, as well as it avoids exposure of as much as the ocular tissues to gene therapy. Another format that's being looked at by some companies is by actually injecting a medicine into the vitreous cavity, which is obviously easy to do in clinic, but you run the risk potentially of having more exposure to this, and so you might have more like inflammation, which I'll talk about in a little bit. So the AVA program is looking at suprachoroidal for this, and in the 106 patients who are enrolled in the studies, there was a meaningful reduction in terms of the amount of treatment that was needed in certain dose levels, looking at the 6-month results. Here's a little bit about how the technique is done. If you're putting it underneath the retina, you need to inject 200 microliters underneath the retina in a single bleb. And I have a little video that's showing that, and we'll talk about that a little bit more later. But you can use a 41 gauge cannula to make sure that the drug is being delivered underneath the retina to create hopefully one single bleb, and making sure to stay outside of sort of the macula that's there. The phase 3 studies are ongoing. So Ascent and Atmosphere, looking at the subretinal delivery. So Ixo-vec is another agent that's being looked at. So it's an intravitreal vector that's carrying an aflibercept coding sequence. The phase 1 OPTIC study looked at this, and we have 3-year data from this, which showed that there was also a meaningful reduction in the amount of injections that were needed for these patients, including at certain dose levels. There was 84%, as well as 50% or 53% of the participants actually didn't need any injections at 3 years. The phase 2 LUNA study, which has enrolled 60 patients, also showed that over 50% of patients actually needed no injections at 6 months of 2 different doses as well. Another target that's being looked at is 4D150, which is a dual anti-VEGF transgene that expresses aflibercept and VEGF-C in inhibitory RNAi, and this is dosed as a one-time injection into the eye. It's being looked at in the phase 1/2 PRISM study that's enrolled 51 patients, and these are patients who really needed a lot of injections for their neovascular AMD. And 3 of the patients who were treated with the high dose actually were able to go without injections at 1 year follow-up. So I'm going to change gears and talk about gene therapy for geographic atrophy now. So JNJ-1887 is a one-time intravitreal injection that's under the investigation for a GA. And the goal of this gene therapy is to increase the expression of CD59, which inhibits the MAC formation, which is the terminal step in complement-mediated cell lysis. And this is thought to help protect retinal cells just with a one-time injection. The phase 1 study enrolled 17 patients, and although the primary endpoint was really looking at sort of safety, they did notice some promising efficacy measures for the high-dose cohort with a continual decrease in the lesion growth looking over 6-month periods, as you can see here, through 24 months. So this is now being investigated in the phase 2 Parasol study, which is still enrolling patients but getting close to closure. And this is looking at patients who have extrafoveal GA. Another agent being looked at is ASP7317, which is subretinal therapy derived from human embryonic stem cell-derived RPE cells to treat geographic atrophy. And there's a phase 1b study that's enrolled approximately 18 patients and is evaluating different doses. Another one is RG6501, which is a suspension of human allogenic RPE cells that's delivered underneath the retina. And in the phase 1 study, there were outer retinal changes seen in a positive direction on the OCT. And the phase 2 study is going to look at 60 patients. So it's really exciting to have all of these innovations and potentially great promising efficacy results. But I think the thing that I haven't mentioned and that we need to keep in mind is that there is a concern for inflammation in these patients. As we know, that's been seen in sort of other gene therapy studies and treatments that have been used for the eye. I don't pretend to be a uveitis specialist. Sunil, unfortunately, couldn't be here, but I have lots of friends who are retina specialists, some of whom are on this panel. I have a feeling that I know what Sunil would say if he was here, because he let me use this slide and the next one, which are his slides. But all viral-based gene therapy will cause inflammation, and this inflammation is usually dose-dependent. And dose in this category is really viral load. So it makes sense that if you're transfecting more of a treatment, that you're going to inherently cause an immune-like response. And the immune response that we're seeing could be secondary to the vector itself or to the neutralizing antibody. So it's hard to sometimes, I think, differentiate in these patients if we're seeing inflammation or pigment release, or is there some toxicity going on. So I think we have to sort of accept that all gene therapy will lead to some degree of inflammation, regardless of sort of how we give it in the vector type. And we just don't know yet how long it's going to take and how severe it's going to be. So we're really not sure yet of what the long-term effects are. But we also have to keep in mind that for some of these diseases, the long-term effects, we have to think about if these are going to be worse than actually having the disease itself and what that risk-benefit looks like. So really, we should, in these patients, sort of in general, sort of probably over-imaging and really try and come up with better metrics to be able to sort of quantify how much inflammation is there. So in conclusion, we're lucky in Retina to have such great neovascular and GA treatments currently available, but all these treatments really need high injections for patients, which is a challenge for patients or caregivers and those of us taking care of them. But there's also a concern for sort of undertreatment. So having potentially in the future other effective treatments would be really helpful. And multiple agents sort of utilizing gene therapy are in development and might help with this problem. Thank you so much, guys.
Any questions, Carl?
Kat, I did have a comment about, I'm glad you raised the point about gene therapy with inflammation. It is dose dependent. It doesn't seem to be related to neutralizing antibodies. And intravitreal is going to be probably more likely to produce pan-uveitis or intraocular inflammation in all compartments. Suprachoroidal probably less likely, probably more localized. And subretinal, the least amount of inflammation, at least something we don't really see or detect. But all of them also, well, subretinal and intravitreal seem to also be potentially disrupting pigment to some degree. At some point you might see pigment cells or depigmentation either under the retina or iris and so forth. So that's another safety concern we're closely watching.
Thank you.
You have, Jenny?
Yeah. Kat, that was a great presentation. I have a question with regards to continuous inhibition of VEGF, because you're constantly giving anti-VEGF with the gene therapy with no recourse, if you will, to shut it off. Is there any thought of putting a tag on there so you can turn it on and off?
It'd be nice if that was possible. I don't know if that's something that's really sort of in development yet, but I think it raises the question of, what are the consequences of having like sustained anti-VEGF? Is there going to be worsening atrophy in these patients? What's that going to look like? And I think the concern that we have is it's great to have a one and done treatment, but do we want to have a one and done treatment is the other question. Thank you.
Thank you, Kat. Next up, we have Justice Ellers talking about OCT biomarkers in intermediate AMD and GA. Justice.
Thanks, Alexandra, and thanks for the invitation today, and thank you for everybody being here. So I'm going to switch gears and talk a little bit more about imaging, specifically to OCT and dry macular degeneration. These are my financial disclosures. So as we've heard already with some of what Kat was discussing, we're really entering into a new frontier in terms of dry AMD therapeutics. We've had approvals for new treatments here in the US for geographic atrophy, and there's a real excitement of going beyond GA into intermediate AMD. But one of the biggest challenges for us is the speed of the disease, as well as really identifying biomarkers that could allow us to understand therapeutic effect, but also design the right clinical trials. So when we look at this, OCT is a tremendous opportunity. For years now, multiple groups have shown that there's really some key things on OCT that can be linked to progression risk. One of the questions that we have is what really defines progression? Is it progression to GA? Is it progression of photoreceptor loss? And some of that ends up being defined within the field, but some of it's defined by the FDA, and what will they actually approve? When we look at SD-OCT, there's been multiple things related to drusen, and the retina hyperreflective foci, for example, has been consistently shown to be a progression risk factor, as well as the complexity of the drusen themselves. We've seen from the CAM group new definitions related to OCT features in dry AMD, such as Aurora. When we look at the biomarker sequence, that's also something that's important to understand is where do we start? And if we think about some of the things as we've been looking at this within our research, it may be that with the intermediate AMD, you start with drusen, but relatively preserved outer retinal structure. You move on to ellipsoid zone loss. And at Macula Society this year, Vasada presented an interesting study where he looked at eyes that had hyperreflective foci and looked backwards. Because of their clear link to progression, you want to know where did we start. And what they found was that almost uniformly, if you had hyperreflective foci, you had ellipsoid zone loss preceding that. You then develop hypertransmission defects and then subsequently on to iRORA and then geographic atrophy. So these are all new potential OCT-based endpoints. And I'm going to focus on two that you may hear more and more about in the trials that are emerging here. The first is in quantitative ellipsoid zone integrity. So why would we think about the ellipsoid zone? Well, this has been well established across retinal diseases in terms of the functional link. And this is something that's really important when we look at why a drug would be approved and why would we want to treat our patients. It has to have a functional impact. And we've seen this not only in things like macular degeneration, but in other diseases as well. But many of these early diseases were just, when we looked at this and characterized it, were either linear measurements on the foveal B scan or qualitative assessment. It's been very difficult to actually apply it in a pan-macular way until recent technologic advances. But can we apply it to intermediate AMD? And this is one of the questions that we hear a lot, is there's multiple specific challenges related to the complexity of the anatomy. This includes drusen. For example, are the ellipsoid zone changes we see, are they just artifacts? Are they from compression? When we look at this as well, there's directionality concerns. Brandon Lujan has done some really interesting work showing that the ellipsoid zone and other retinal bands change as the angulation changes. But interestingly, he also presented that in AMD, that directionality is not as significant. So when we look at this in terms of how do we get to a point where we can measure this, can you do it at a reading center level? I'll talk a little bit about how we got to where we are. So one of the things that has just made a huge difference is applying machine learning to improve our segmentation. What we use is actually a multi-model, multi-architecture system that uses different features such as detecting geographic atrophy or detecting hypertransmission to feed back on the different layers that are being detected as well to be able to generate something that's more and more consistent. You want it to be agnostic to multiple OCT systems, and you want to be able to have it be interpretable so that at least at the FDA level, you can have a human look at it, edit it, correct it in whatever way that's needed. And one of the things that we found is you want a high-intensity training program for those readers to be able to consistently look at this and see what is ellipsoid zone loss in complex diseases. So we see here examples here of an ellipsoid zone integrity map with total EZ attenuation as total loss of the photoreceptors, and partial EZ attenuation is where we see early degradation. Another area that's been looked at is EZ intensity and the overall reflectivity, and multiple groups have shown also here that this is linked to function, but it's also much more challenging, at least in our experience, in terms of potential imaging artifacts. So the question is, can you consistently measure this? So we looked at this completely manually, which is brutal from a time burden standpoint, and found that, in fact, if you have the right training program and the right readers, you can very consistently measure this across the board. But what you really need is something that's scalable to be able to be automated or semi-automated, which also shows very high consistency. So when we look at some of the definitions, we now have an FDA approvable endpoint for dry AMD, which is a change in total ellipsoid zone loss in area, and we now have some programs that are actually looking at that. We've seen therapeutic signal already in advanced AMD. The Stealth Reclaim 2 trial was the first study to pre-specify this as a secondary endpoint, where they showed that using elamipretide, there was a significant reduction in total EZ attenuation loss as well as partial EZ attenuation loss at week 48. When we look at the phase 3 programs, there's also consistent signal that complement inhibition, both in the GATHER programs as well as in the Apellis programs, have shown that using complement inhibition slows down photoreceptor loss. And these are done with two different methods and also is encouraging to understand what we're seeing in that signal. In addition, now there's a phase 3 program that's been launched by Stealth to look at this as the primary endpoint. One of the other things as a biomarker is we want it to actually be a signal for faster disease progression. We've seen this in Derby and Oaks. This was work done by the Vienna Reading Center, showing that based on quartiles, overall greater photoreceptor loss excess leads to faster GA progression. We saw similar findings in the GATHER program as well, again, consistent for what we're seeing from a scientific basis of that photoreceptor loss likely precedes GA progression overall. One of the important things is there that functional signal, and this is one of the real challenging things that many of the GA programs have been looking at is how to define that. Some of that may be based on the study population that's there, but when we look at it in intermediate AMD, what we've been able to see is that those eyes that have really good vision have much less overall EZ loss compared to those eyes that have worse vision. This translates into eyes with geographic atrophy as well. And one of the interesting things, though, is that if you start to talk to patients who are coming in with other symptoms, such as dark adaptation or other challenges such as with reading and their vision's still good, look at their ellipsoid zone. Oftentimes you'll see that it's compromised. We looked at this in the GATHER program, and also so that those eyes that were losing vision were those eyes that were also losing photoreceptors. In addition, when we looked at baseline features, we found that those eyes that had significant vision loss were those eyes that had the most significant compromise at baseline. So when we look at intermediate AMD, can we predict progression over time? This here is from a natural history study that we did that shows a non-progressor, a drusen map here on the right, as well as the ellipsoid zone integrity map that shows overall good photoreceptor integrity. This is an eye that progressed to subfoveal GA within 2 years. We see no signs of geographic atrophy, but you can see the geographic atrophy pretty much emerges within that zone of ellipsoid zone loss. When we created a machine learning random forest classifier, we found that the photoreceptor integrity measures were by far the most important driver of what determined accurate classification of those eyes that went on to GA. So when we think about intermediate AMD and ellipsoid zone integrity, this really is something we're going to hear a lot more about, as well as in the geographic atrophy space. This also seems to be a potential faster changing biomarker as well, and we'll be seeing this, I think, in future trials coming forward. The last biomarker I want to talk about is hypertransmission. When we think about hypertransmission, it was something that the CAM group really talked about that defined more advanced, intermediate, and early advanced AMD. We see it obviously in geographic atrophy, but Phil Rosenfeld has really pioneered this as a potential biomarker using specific SLAB techniques with OCT to be able to identify persistent areas on FOS-OCT. One of the exciting things is this can actually be measured without using specific scans. And we've been able to do this with standard OCT acquisition. And there's currently some FDA guidance that this may actually be an allowable endpoint, and we're going to see this in some of the early trials as well. The other things that we may be able to do with hypertransmission and some of the other biomarkers is start to pair things like hyperreflective foci with these to see greater risk for overall change with time. This is something that we presented at Angiogenesis, which showed that when we looked at hypertransmission overall in the phase 3 GATHER programs, we saw similar results to what we saw in geographic atrophy, was that the hypertransmission area excess, so this is beyond where the geographic atrophy is, also was reduced with ACP treatment. This is an example here of what we might see with that hypertransmission overlay at visit 1, visit 2, visit 3. The geographic atrophy ground truth is there in pink in the third column, and then the ellipsoid zone integrity map as well. So we see all of those leading biomarkers that are in excess of where we see the geographic atrophy, and again, maybe earlier indicators that we can intervene on, maybe actually have faster trials to understand decision points, particularly in some of the phase 2 trials before going on to phase 3. So in conclusion, there's multiple exciting emerging biomarkers that really hold promise for us as a tool in clinical trial enrichment, as well as for future clinical trial endpoints. Ellipsoid zone integrity in particular is promising, particularly with the FDA guidance that's there. And we're going to see this both in terms of geographic atrophy and intermediate AMD. And persistent hypertransmission as well represents an earlier opportunity to understand disease effect before geographic atrophy growth. More research is really needed to continue to link this to how we see function in our patients and how we design those trials. And again, I want to acknowledge my team at the Cleveland Clinic and thank you for the opportunity to be here.
Questions for Justice? I was curious, I think the Z stuff is fascinating, right? And you mentioned that there's this problem we have with GA, structure and function. And you commented on best corrected visual acuity. Have you guys looked at any other assessments of visual function?
So one of the challenges, not yet in a way that we can really hang our hat on. One of the challenges, microperimetry, which really probably holds a lot of promise to do true structure function correlation, is often optional. And so when you look at some of these earlier studies where they didn't realize how important function might be for approval, you may have very small groups where you have that ability to do that. We're going to see more and more in the trials, very targeted microperimetry patterns that can then be linked to the photoreceptor structure. So I think that holds a lot of promise to be able to look at that in the future.
Any other thoughts? Wonderful. Thank you, Justice.
One question out there.
Oh, there's a question. Oh, I'm sorry. Please go ahead. I didn't see.
Other than future clinical trials, how could these biomarkers affect your clinical practice?
So for me, one of the nice things is that even though this uses advanced technology to quantify this, as clinicians we can see it in front of us. And I guess anecdotally what I would say is I got in the habit of a patient would come in, they're 20/20, busy clinic, you say you're doing great, and they'd say, no, I'm not, I'm getting worse. And they'd say it every single time. And now I really look at it, and you can see that progression there. And certainly what we're seeing more and more with GA is who are you going to put on treatment? We know that there's been work done both in both phase 3 programs that show that those faster growers may benefit most from complement inhibition. And so if you can identify some of these changes, for example, photoreceptor loss in excess of where the GA lesion is, I think you're more likely to identify those patients who would benefit most, and you can get sooner to therapy currently. Great, thank you.
Thank you.
Okay, so it's my pleasure to speak today on clinical trial design and FDA guidelines. Where are we now and where are we going? So we've heard some wonderful talks already this morning about some of the new treatments. We've heard about some of the endpoints. And this talk will kind of put it all together in terms of what does the FDA actually require? What is an approvable endpoint? These are my financial disclosures. And seeing as how I'm talking about clinical trials, they are all relevant. So I've titled this talk Clinical Trials 2.0 for 2024, and I'll basically discuss what are the FDA recommended clinical trials designs, what are the recommended clinical trial endpoints, and then give you examples of both the trials and the endpoints. So where can you find this information? The FDA has actually put out guidance documents, which they call draft guidance for industry, and there's one for neovascular AMD, and there's also one for gene therapy for inherited retinal diseases, and I strongly recommend that you look these up online. And within these documents, you'll find the guidelines for comparator arms for setting up clinical trials. You'll find out what are the population, participant definitions, safety measures, and efficacy outcomes. So first, let's look at AMD. In terms of age-related macular degeneration, in 2023, there were some new guidelines that came out. And these guidelines recommend some changes in the comparator arms. So we know that when you put together a clinical trial, you're comparing an investigational drug typically to a standard of care drug. And so each investigational arm has to have at least one comparator arm. Now this comparator arm or arms and the investigational arm now are required to have the same dosing frequency, the same criterion for dosing adjustments, and lastly, the same criterion for intervention. So this is new. This means that the previous designs that you have seen in these phase 3 trials in Tenaya and Lucerne for AMD, and then for Pulsar for the aflibercept high dose, are no longer approvable. So these designs would not be approved today. And why is that? Well, if you look at them, you see that the investigational arm has a different loading than the comparator arm of aflibercept 2 milligrams. It also has different rationale for retreatment, right? The intervals are not the same. So this is a problem. So how can we actually do something now and put together a clinical trial? And then also on top of that, the FDA also does not want sham injections. Okay, so you think, well, is it really ethical to have a control where you inject, say, saline in there? So these are all the challenges that now we're going to have to deal with in 2024, beginning in 2023. So this is one of the new drugs, Axpali, which is an axitinib, a tyrosine kinase inhibitor. And this is how a new clinical trial potentially would look like. So basically, you have the same treatment dosing at the beginning of the investigational drug as well as the aflibercept, and then at every time point, everything has to be the same. So you can't treat one and not treat the other. You can't have a sham or injection. You have to have a control group. So these are some of the challenges, and this is why the clinical trials designs that you're going to see for this, some of the studies that you participate in are going to look very different from what you've seen heretofore. Now, in terms of clinical trial designs, the FDA also prefers superiority trials. That is a parallel group, randomized patient double-masked study in which you compare the investigational drug to a control group superiority design, everything similar. Now, if you can't do that, a second option is to do a non-inferiority trial, where again you have parallel groups, you have the investigational group, and then you compare it to the standard of care. And in the non-inferiority, the treatment comparison would be a double-masked either to ranibizumab in the case of AMD monthly, or to aflibercept Q4 or Q8 after 3 loading doses. And so this is what potentially this trial would look like if you were trying to do a non-inferiority, you would have to compare to the standard of care dosing. But also, though, you would actually have to, for masking, the FDA would require to have a control injection arm as well. So you're going to see, again, some designs that you've not looked at before and that might not make sense at first glance if you don't understand where the rationale is for this trial design. So in order to get a drug approved, the FDA also requires certain different characteristics for gene therapies versus for AMD. So let's look at some of the gene therapy requirements. Again, randomized concurrent parallel control groups when possible, and they say for the control that the vehicle alone can serve as a control if it's ethical. Now, pediatric patients, this may not be ethical, right, injecting just the vehicle in kids, so there are some nuances that also have to be considered. Now, an alternative to using a vehicle control is that you can do a dose level or an escalating dose level, try different strengths of the drug as a control to the intended dosing for that study. And you've seen some of these in some of the studies that have been shown. Also for gene therapy, it's really important that you have to reduce bias, okay, when you're treating these patients. You have to have masking that's very, very good to reduce this potential bias. In the 2 treatment arms, there's a recommendation that you have 2 different doses, but with the exact same procedure, so you again don't unmask the patient. And again, as I said before, the second treatment arm can actually be a dose-ranging control study. So now let's talk about the population. So now you have your AMD population. You want patients over the age of 50 years, men and women, and then with the NEI initiative, the all of us, the inclusivity, there is an emphasis now on multiple racial and ethnic involvement, inclusion into the cohort, as well as multiple eye color groups. In terms of AMD, that is neovascular AMD, the CNV should be documented by fluorescein angiography, OCT, and photos. And when you're doing the superiority trial design, the patients should have visual loss or should be expected to develop visual loss without treatment. Those are the ones that you put in. If you're doing a non-inferiority trial, it should be including patients who have choroidal neovascularization with visual loss in that group. In terms of gene therapy, the FDA requires that there is confirmation of the genetic mutation, right? It makes sense. You want to make sure that what you're including really is the disease that you think you're enrolling. So make sure there's genetic confirmation. Then also, when you select your patients, you have to make sure that there is the possibility of benefit in these patients, right? Because you don't want to enroll a patient just to see how your gene therapy, if you will, takes, because some of these patients may have already had irreversible visual loss and there's no benefit. So look very carefully at the benefit risk profile and when you're defining the population. In terms of the early studies, these mostly will focus on evidence of efficacy and can be dose ranging. But for the later phase studies, these will focus obviously on efficacy. In the treatment for genetic diseases, there is an emphasis that you should treat both eyes. However, that doesn't mean you don't have a study eye. You still have to have an initial study eye, and you have to have criteria defined in your protocol and how you select which is the initial eye that you treat. And then you have to have separate treating and separate evaluating investigators to limit bias. And then also there should be an exploration in the protocol in terms of how you're going to retreat, because sometimes a gene therapy won't take right away. We heard a beautiful talk today on how gene therapy is being developed, but sometimes you have to give more than one dose, so that should also be in your protocol. Now, this part hasn't really changed in terms of what is required for FDA submission in terms of at least 2 adequate, well-controlled, multi-center clinical trials that utilize different investigative sites. And again, 1 study eye per patient, although you can include 2 eyes of the patient, but if you do that, the safety data has to include both of those patients. In terms of something relatively new, there is a required controlled safety trial that must be included for 2 years for each new drug. And in terms of the safety, what exactly does this mean? Well, you have to have at least 400 of your patients who have received the investigational drug at the planned dose and frequency that you're asking for approval. You also have to have at least 300 patients who've completed at least 9 or more months of follow-up. And then if there is a risk of minimal systemic exposure, then systemic and lab evaluations at baseline and 9 months are adequate. Otherwise, you need more systemic and lab evaluations throughout the clinical trial. In terms of the safety for gene therapy, there must obviously be, as we've heard, monitoring for intraocular inflammation because this is a real possibility. You have to monitor for systemic side effects. There must be a consideration and a justification for the determination of which immunosuppressive that you're going to use before and after the gene therapy product. And then, of course, you have to monitor for complications related to immunosuppression, also required. In terms of clinical trial efficacy outcomes for age-related macular degeneration, statistically, you have to show that there's a significant difference between the investigational and the control arm. And classically, this has been visual acuity, right? We've all shown that there's smaller percentage of patients who are treated that have doubling of the visual angle at 9 or more months, so basically they lose less vision, or you have a larger percent of patients who have halving of the visual angle at 9 or more months. You can also use the mean change in best corrected visual acuity, typically a gain of 15 or more letters at 9 or more months, or you can do an inferiority trial in which the difference between the investigational drug and the comparator confidence intervals is greater than minus 4.5 letters at 9 or more months. Now, this is important to realize that the decrease in the number of the administrations of available effective therapies alone is not sufficient for the demonstration of efficacy. So we can do an add-on treatment, and you can say you decrease the treatment from, let's say, 6 in a year down to 1. That is not going to be good enough for the FDA. A little bit frustrating, from the part of a clinician, right? Because we want to be able to decrease the treatment, but that's not an approvable endpoint. In terms of endpoints, your endpoints really are meant to evaluate the risk to benefit profile of the drug or the medical intervention. It must be clinically relevant. It must be sensitive to changes by the intervention, and it needs to be validated. And Dr. Ehlers presented a beautiful talk on multiple surrogate biomarkers and endpoints and the fact that they do correlate with disease progression. So that's part of the validation. So these clinical endpoints are typically visual acuity, visual field. Obviously, these are subjective, and you require large numbers and longer duration. And because of this, we sometimes use surrogate endpoints. So let's just quickly look at some of the visual acuity endpoints. These can range from typical ETDRS visual acuity to low luminance visual acuity to something called low luminance deficit, or the difference between low luminance visual acuity and standard visual acuity. And you can also look at contrast sensitivity. So these are some of these functional visual acuity endpoints. And the traditional endpoints, again, are gain of 15 or more letters as well, or you must define a minimally relevant change in the number of lines lost or gained before you start your study. It's also, however, important to realize that visual acuity, for a lot of the new trials that we're doing nowadays, is not really relevant, right? Because we're taking patients who have relatively good visual acuity, say early geographic atrophy where the vision's not involved, inherited retinal disease where you're trying to prevent visual loss, or patients with glaucoma, say, where the vision has not yet dropped. So for these patients, visual acuity alone is not a reasonable endpoint, and you have to come up with other endpoints. Some other endpoints that are functional include microperimetry endpoints, chromatoperimetry, even visual field and ERG. And in fact, in the phase 3 AAV8 gene therapy for retinitis pigmentosa gene therapy, X-linked, they're actually looking at visual field as a primary endpoint. It's also important to realize in 2024 that functional vision, that is quality of life, is really an important endpoint for clinical trials and is also being evaluated in regulatory approval for new drug therapies and interventions. And some of these quality of life measures include the NEI VFQ-25, the IVI, and the VF-14, and you'll probably see many more of these. Now, we've talked about the clinical endpoints, and just briefly, some of the surrogate endpoints that are being used to replace clinical trial endpoints have, as I said, been already discussed by Dr. Ehlers. And these, again, you have to show that they're biologically plausible and that they are validated before you use them in the trials. And these are typically ocular imaging biomarkers. Again, requiring a strong correlation with patient benefit and linking to visual function. And these are primarily used for geographic atrophy. In the retina field, we've got lots of these biomarker endpoints: autofluorescence, OCT, OCT-EZ, and fluid, to just name a few. In terms of geographic atrophy, the mean change in geographic atrophy lesion area as measured by fundus autofluorescence was used in the phase 3 Chrome and SPECTRI lampalizumab studies, and this showed that the mean change in GA area from baseline to week 48 was actually not clinically significantly different, but that was the endpoint that was used. Other studies that have had a positive endpoint have looked at the growth rate of GA. We saw this in the Derby and Oaks, and I won't dwell on this because Dr. Ehlers again showed some of these endpoints. Similarly, also in Gather 1 and Gather 2. So these were primary endpoints that were useful structural endpoints that led to approval of these drugs. DRSS score is also useful as a primary endpoint, and the fact that a greater than 2-step improvement on the DRSS score is significantly clinically of benefit has been used in the Panorama study. And in Panorama, we used a greater than or equal to 2-step DRSS change from baseline to week 24, and this led to the approval for the aflibercept to be used for improvement of the DRSS in patients with moderate to severe NPDR. It's also being used in the APX 3330, which is an oral drug looking specifically to see if we can improve the DRSS score in patients with diabetic retinopathy. Other non-primary endpoints include retinal non-perfusion. This has been used in the recovery trial. And then some other novel endpoints, which has again been discussed already, is EZ disruption. And in the MACTEL primary study, the primary endpoint was the difference in the area of EZ disruption at 24 months. In the NAC attack that we're involved in, and I'm sure many of the panelists here are also, the primary endpoint is the change in the EZ width of the retinitis pigmentosa patients at 45 months. So, you know, when you do these studies, you're going to find that sometimes what you're studying doesn't really have a really good endpoint. And you have to work with the FDA sometimes to develop acceptable endpoints. And this was actually done for the gene therapy for Voretigene, the Parvovec, which was approved, obviously, for treatments of these patients with RPE 65. And what they did is they developed a mobility test under different levels of illumination. And you might know it as the MLMT test. And this was the primary endpoint that they used to show that patients who got the investigational gene therapy did better than their control patients. So novel endpoints may be required. So in summary, in 2024 Clinical Trials 2.0, you have to know that there are new recommendations for AMD and gene therapy designs. You have to know about new approvable endpoints in terms of efficacy and safety. Thanks for your attention.
Great talk. Any questions for Jenny? Anybody from the audience? I was just curious, you know, these guidelines, you know, there's quite a lot of changes. And how much input do physicians have in development of these guidelines? How do they get developed?
That's a great question. I think there's a small cadre of people that are involved in this with the NEI, and probably Dan, you look like you want to say something. There are people who they consult with and help with this. And I think there's been also a change recently in the FDA with Wiley stepping down, so I think we're going to see yet more change in this.
It's hugely variable. So, for example, the GA endpoints, that was years of multiple meetings, large sort of groups that came together in multiple locales. The most notable one was they actually had a meeting at the NEI and sort of agreed on what should be an acceptable outcome for progression of GA. But most of the changes that you've just mentioned, and don't listen, this is a big deal. This just got a lot harder. I mean, there's a couple of things in here that are completely unacceptable to me and to many of us. We've been asked. A whole bunch of biostatisticians who, like Rick Ferris, Maureen McGuire, Roy Beck, Alan, basically all the leaders of these trials, and then people in leadership roles, myself and Jenny, we've been trying to think about what can we do to address some of this stuff? Because, for example, a 15-letter gain over and above existing therapies is just simply not achievable. Or the requirement to do a sham injection when study after study has shown that masking is not nearly as, okay, I'm a clinical trialist, but what I'm about to say is heresy, okay? But it's not nearly as important as people think it is. The whole goal is to eliminate bias. And in CAT, people weren't masked. And yet at the end of the study, 50% of people had no idea what they had been receiving, despite the fact they'd received a letter in the mail every month, a Medicare summary notice that told them what they were getting. They didn't know, right? And so we did the same analysis in multiple trials in the DRCR Retina network. And with no masking at all, people don't know most of the time. And there's some trials that you can't mask. There's some things you could do to look at, did that insert bias? You can show it probably didn't. So this idea that you have to give an intravitreal injection of saline or a vehicle is just ethically challenging to many of us. So, but those are the rules, and those were pretty much made by one person who I like and respect, I've known for a long time, worked with, used to be a consultant for the FDA for many years. But wow.
There is some good news, though. There is some wiggle room and some with regards to the masking issue. Obviously, as you said, you can't mask solution versus an implant, for example. So it's more about totality of data, and there is some. These are draft guidelines. Number one, it means they're guidelines and they're draft, and so they're not necessarily written in stone yet. So this is going to evolve, and they're hearing from us. So it may make studies larger, more expensive, more cumbersome for sure, having 2 comparator arms, for example, and things like that. But the good news is this notion of a vehicle injection control is probably not going to go forward. So that's not a mandate per se. That's good news.
Justice?
Jenny, I'm curious. That was a great overview. When we look at some of our new endpoints as well, one of the interesting things, particularly in some of the newer drugs, is they weren't necessarily evaluated on those endpoints. Do you have a sense of what the FDA's receptiveness would be if a new drug is going to come out for the same indication, but for a different endpoint, whether or not they would require a comparator when there's no label? For example, if you looked at photoreceptor preservation, do you have thoughts on that in terms of, with the new guidance that they're giving us, and they're really pushing on the comparator side of it, but it's an interesting space.
Yeah, they are pushing on the comparative side, but then on the flip side too, they do welcome discussion with them to create novel endpoints. And so that's, I think, where the wiggle room is as well. And that's where I would push back. And I would say, look, this is a novel endpoint. There's biological plausibility for this. It would make sense. And go ahead and, list other trials that have had other novel endpoints that we've shown here. And I think they would be pretty reasonable with the new administration that's in place right now.
Yeah, except that the person who's right now is in a temporary role, and so they're not going to change anything. We're going to wait for the permanent, for the person who's going to succeed that. Yeah. Some of the things that were changes that were made are reasonable. You touched on it very nicely. Basically having symmetry in dosing between arms, so that you don't wind up with this. You understand why Tenaya and Lucerne were designed the way they were, and Hawk and Harrier the way they were, and they were correctly designed. I mean, aflibercept was to basically use anything different than the label would require them to hold an IND for a drug that they don't, that the company doesn't own, and it just gets really messy. So it's reasonable what was done, but going forward, the agency has said you can't do that, because what it does do is lead to these ideas that one drug really might last longer than another when you really haven't done the head-to-head.
And it's interesting too, Dan, right? Because we wanted to try to give a treat and extend arm for aflibercept, and we were told by the FDA you couldn't design it that way. You had to be on label back then.
Yeah, you have to have the on-label arm, but you can then have that second other arm so that you can get it to have parity.
$100 million.
Yeah, that's where the increase in size and money come into play. But that's what you're going to see mainly going forward. They're really just aiming to minimize the gaming to make a product that of a study design that makes a product look more durable than it might really be, or to look more durable than another product that hasn't been shown necessarily in their study design to look that durable. That's all.
Great discussion. Thank you, Jenny. And
So I'm going to talk about sustained release strategies for retinal disease. Dilsher and a few others have covered some of these topics, but I'll go a little bit more in detail here in my financial disclosures. So the retina community really wants durable options. You can see that people are really looking for obviously durability in the ASRS PAT survey, and then they want better long-term outcomes. We know that vision has declined in most patients in long-term studies. And again, the drying effect is very important to individuals. Maintaining the retina dryness is a very important thing. So this is what our community is saying and what we need. And what we have right now is newer drugs that have certainly increased our durability for sustained or certainly durable options. These are some of the ones that have been FDA approved recently. I'll touch on ranibizumab port delivery because this truly is a sustained delivery implant. But just to cover these other two drugs, I think is important for first, aflibercept 8 milligram and faricimab have both shown some increased durability. So this is Tenaya and Lucerne. At 2 years, greater than 60% of patients on faricimab were actually Q16 weeks of dosing, and 80% achieved a Q12 week or beyond dosing, which is, again, good durability in clinical practice. If you look at the other study with Pulsar for neovascular AMD for high dose of aflibercept, you see a very good, again, signal here. 78% of patients on aflibercept HD achieved a Q16 week of dosing, and 53% achieved Q20 week of dosing. So we have some pretty good options right now in our practice, but realistically, we need even longer duration potentially if we really want to have our patients. And the biggest reason we fail in some of our patients and their outcomes is really their inability to come back and see us. I'm taking care of snowbirds now, which is kind of interesting. They definitely want to come back and get treatment, but they're interrupted when they go back up north and they come back to the Florida area to be seen. And so we have options potentially in the pipeline. I'll talk about some of these drugs and what's happening. Let's touch first on port delivery system. This was actually approved after the Archway study. This was an open-label randomized clinical trial of patients who were previously treated for neovascular AMD. And the primary endpoint was the change in visual acuity, which it did achieve. And in fact, on the top, you see the center point and thickness of the retina. It didn't change a bit with comparing this to monthly ranibizumab treatment. But it did have some adverse events, one particularly was vitreous hemorrhage, which was really within that first post-operative period. But following that, what they found essentially was there were two major issues. The first was that they did some artificial lab-based testing and found that the implant failed those testing regimens. The second was septal dislodgement, which was the other issue. And this is what it looks like clinically. So because of the fact that people were essentially placing the needle improperly or really pressing on the septum, this caused septal dislodgement. And back in 2022 was when this is first reported, they found 33 cases and 1,400 implants. About 2.3% of patients had this effect. And if you look at this, again, when they followed this over the real world, it was about 5.3%. So quite a significant number of these patients had this. And really this was related to the design of the actual septum, and I'll talk about what they've done. And even the refill needle, it required a lot of effort to, first of all, get it through the septum. So it needed a significant amount of force. Actually, people had to use a microscope to do this rather than using loops. This was not something you could do blindly in the office. It really required, and the clinical trials have now resumed with this newer design implant you can see here. So the big thing is what's shown essentially in that circle, the red circle, which is a septum overmold. You can see that difference between the recalled implant and the updated implant, which hopefully will be better and more stable as a result of this. And in fact, they also looked at updating the refill exchange needle. And this is a study where they looked at, again, 10 years of clinical use. And what they found essentially with the old implant, they had about a 47% chance of making it between about 21 punctures. Now with the new updated needle, they get essentially up to 36 punctures with 52% of that updated needle achieving that survival test. So again, a nice improvement in both the needle and the septum together, and that's being studied now. The other drugs that have really been impressive from a standpoint of trials and implications in our practice is tyrosine kinase inhibitors. And this is a nice little summary paper that's emerging drugs that was a peer-reviewed publication we put out this year. And tyrosine kinase inhibitors essentially are affecting the intracellular downstream effects of both the angiopoietin receptors as well as the VEGF receptors, and you can see them on the bottom. And there are a variety of different targets, and they differ as far as their IC50s, as far as their ability to affect those intercellular receptors and those enzymes. Axitinib and vorolanib are the two standing drugs out there. The lower the IC50 is, the more potent these drugs are. And you can see that both axitinib and vorolanib have really good potencies of VEGF receptor 2 without any Tie2 clinically relevant doses. You don't want to inhibit the Tie2. You want a Tie2 agonist in this case in order to prevent downstream effects. And therefore, these drugs don't affect that. Vorolanib was the first drug that's really been involved in a lot of early phase clinical trials. EYP-1901 is actually a bioerodible insert. It's a Durasert implant. So if you're familiar with the fluocinolone implant, this is a very similar approach to that, delivering that drug over zero-order kinetics, and affects both VEGF receptors and PDGF receptors in these patients in the drug. The implant looks like it does here on the bottom of the screen. You can actually see that. This is 5 months post-implantation. And again, there's no polyamide gel here. This is totally bioerodible, has zero kinetic order of discharge, and it's meant to last about 6 months. And there was a study called the DAVIO 2 study, which randomized patients to receiving 2 different doses of EYP-1901 versus aflibercept. Patients were given both the drug aflibercept and the drug on the same day. You can see that they followed these patients over time with sham treatments to see when they required rescuing during this course of this phase 2 study. Patients had previously treated neovascular AMDs. These are dry patients, patients who had good OCTs. You can see that the OCT thickness had to be less than 350 microns on entry and low amounts of fluid. And this is the retreatment criteria, which again, you'll see in a lot of the durability studies, you have to have essentially 5 letters of loss of vision from the best vision you had, a central subfield thickness of 75 microns with that visual acuity change, or again, a 10-letter drop in visual acuity, or a central subfield thickness of greater than 100 microns. So a lot of, these studies were designed to show some durability effect, albeit, again, if you think about this, and this is a good panel discussion to have, whether these are truly relevant to clinical practice, whether we wait this long for these patients. But these patients were, again, previously treated, well balanced in regards to their number of injections prior. They had a lot of activity, 9.5 to 10 injections prior to entry, a year prior to the study. And here was the outcome, which essentially showed that these patients who were randomized to receive EYP-1901 in those 2 different doses had the same visual acuity as those patients who got aflibercept during the entire course of the study. And in fact, if you look at the central subfield thickness change, there was no significant difference here, which is what you'd expect. These patients should remain essentially anatomically dry the entire time. There was about an 89% reduction in the number of injections in the 2 milligram, and the 3 milligram, there's about 85% reduction. You went from a mean injection of about 5 injections in the 6 months prior to about less than 1 injection in the 6 months after that. And here's kind of that attrition curve that shows you, again, 64% of patients were able to be maintained on just EYP-1901, either 2 milligram or 3 milligram during the entire course of the study to week 32. So again, nice safety profile overall with the drug, no significant adverse events, no significant migration of the implant, no retinal vasculitis or occlusive disease with this drug. Again, something we always watch for in these newer drugs and therapies. And this is just a great patient, it's just a good example. The implant was given on day 0, the patient was followed. At month 4, they had a little rise in the OCT thickness to 307. The visual acuity actually was maintained this entire time, but because the OCT was slightly thickened, they retreated this patient with aflibercept. And this patient required no supplemental treatment the entire time after that as well. That was from DAVIO 1. OTX is another company that's looking at axitinib. This is a Lutex technology. This is a bioerodible implant. This is actually currently approved for cataract surgery with a steroid. And they're looking at axitinib, which actually, as you can see, is a little bit more potent than vorolanib. And this, again, is given by a 25-gauge intraretinal needle, targeted release between 9 and 12 months. Another interesting implantation technique here, very similar to what we do, again, with all the intraretinal drugs we deliver in practice. But patients were randomized receiving OTX versus aflibercept in the course of the study. And again, they looked at the same sort of re-injection rescue criteria, very similar criteria what I just showed you in the prior trial. And what again, this is a previously treated population. You can look at the mean retinal thickness there. It's 240 to 270 microns. So these retinas were very, very thin. And again, attrition curve showing you that many of the patients remained without need of supplemental injection. This is that same attrition curve up to week 48. 60% of patients actually were able to be maintained without a supplemental injection. So this is sort of the holy grail, right? This is what we want in clinical practice. You give a single or 2 injections of an anti-VEGF, and then you may achieve some durability. Again, albeit with these definitions that we've kind of artificially applied to these patients. Here's that mean change in visual acuity and central subfield thickness, again, showing you a very stable profile here, which is what you expect to see in, again, a previously treated population. All these patients should have remained stable over time. And again, the safety was really quite good overall. There was one patient with endophthalmitis no really significant rises in IOP or other related adverse events. So overall, a very, very good kinetic profile. And again, just a great example of a patient in this population. You can see the patient received 12 weeks and 16 weeks prior, they received an anti-VEGF. They were randomized to receiving the OTX TKI implant baseline, and they got one aflibercept injection was protocol mandated. And you can see this patient was able to maintain vision with a really dry retina the entire time. I would say this is better than we would expect to see in clinical practice. Some people might say this is just natural history, but I would argue that I don't see many patients like this in clinical practice that were able to maintain this long and again, be able to not be treated like this. And I think that shows you the potential of the drug over time. Safety profile, very similarly, no significant serious adverse events. And again, this is bioerodible, so there was no implant left over at the end of this time period. It's continue on in the phase 3 clinical trial called the SOUL study, which is now currently enrolling subjects. So it's exciting to see many durable therapies coming our way. I'll just say this much. I think our patient populations are quite heterogeneous. So, these durable options may be applied sort of broadly to these patients, but you have some patients that may be one and done. I know in the CAT trial, we had some patients who got a few injections as needed and never needed injections thereafter. So it's important to make sure we use them in the right population of patients. And I think the studies are selecting for that over time. So thank you very much.
Great. Any questions for Rishi? I think in the interest of time, I'm getting text that we are running behind. We'll move on to Kat's panel, talking about some surgical cases.
Awesome. Thank you guys so much. Okay. Let's get started here. My disclosures. Okay, first case. So this is kind of springing off my talk from earlier. So we are so excited to have subretinal gene therapy be in trials. And there's lots of current trials, including this one, but it really involves sort of a different way of sort of approaching and treating patients than we normally do for neovascular AMD and other retina conditions, right? It involves taking a patient to the OR, and these patients can sometimes be older, or in the case of IRDs, younger than our normal patients. And it's a delicate surgery that requires making subretinal blebs. So I'm interested to hear from the panel who, if you're in clinic and you're thinking about signing one of these patients up for sort of a clinical trial, who do you think, based on sort of their anatomy and any other features, might make them a good or bad candidate for treatment? Is there anything that you assess for when you're looking at them or on their imaging? Bob, I think you are pretty experienced in some of these procedures.
I did a lot of the earlier Regenex Bio stuff because I had a lot of patients who were really frequent flyers, we call them, that had 100 or 80 or 70 prior injections, and those people are anxious for therapy of anything that would reduce their treatment burden, and so they were easy to enroll. And I had some really home runs with some of those people. One person's never had another injection. One person wouldn't come back during COVID for the extension trial because I cured her macular degeneration, even though I said, no, I didn't. You need to come back once a year at least. Nope, I'm cured. You injected me 87 times, and now you haven't injected me since the surgery, so I'm not coming back. And, it was really striking. But we had the pigmentary changes in some of these people, and we are using a slightly lower dose now, but those people are the ones that are really desperate, the frequent flyers, the people that need an injection every month.
Mm-hmm. Is there anything that you're paying attention to when you're seeing them in clinic about their sort of anatomy that would sort of make you think that they're like a good candidate or not, in terms of thinking about what you'll have to do procedurally for the surgery? Does that make sense?
Well, there's one obvious consideration is when you do subretinal injections, whether it be cell therapy protocols, gene therapy protocols, you want to have a PVD. So you want to make sure you induce the PVD. And obviously, if you're doing IRD work and they're younger patients, that's going to be more challenging. A lot of us will use triamcinolone in these eyes. So I did cell therapy, subretinal injections, for example, in Stargardt's patients, younger patients. So the younger they are, the more that hyaloid's going to become a challenge, but that's a big consideration. And with the AMD trials for gene therapy, of course, they're selecting pseudophakic eyes because, the vitrectomy is going to cause cataract. So that eliminates that factor.
Awesome.
Oh, another important consideration in gene therapy for subretinal is, depends on the gene therapy. For, we talked about this earlier, for wet AMD, in creating a biofactory, a protein, a therapeutic protein that is your therapeutic, we're putting the bleb in the periphery. For IRD, you're putting that bleb where you need the uptake, which is in the macula, healthier parts of the retina. So very different approach to that. And the same with cell therapy. If you're doing suspensions of RPE cells, for example, that's where you need it, in the macula. But the technique's relatively straightforward. Any vitreoretinal surgeon can learn this. It's a matter of touching down just enough to penetrate the retina. Some people like to do a pre-bleb, which knows where you're in the subretinal space, not the sub-RPE space. There's other little nuances.
Awesome. Yep, there's a question.
Just to mention, regards to our experience with injecting and tuna, realize regards to the technique that if you feel the ILM while injecting, it's kind of easier way of getting a single test.
So your question is about does anyone peel ILM before doing these things? So I can answer a little bit, but I think some of our, because all of this stuff is still in clinical trials, I think some of our procedures are sort of dictated by what are done in the trials. Sometimes people will do, and we'll talk about this in a minute, maybe some subretinal blebs for holes where I think that maybe plays a little bit more of a role. Let's jump to a video. So this is a patient who was undergoing gene therapy. And one of the things that Carl mentioned is always checking to make sure that the hyaloid is up. Interestingly, in this eye, you can see that there's kind of log in and there wasn't a hyaloid up. How often have you guys experienced that where the hyaloid's down? And some of these patients where, to me, it seems a little surprising that the hyaloid be down in someone who's maybe a little older than some of our normal patients.
It's not uncommon.
Unless you've done 100 injections into them, then it's uncommon.
So here we're checking to make sure that the hyaloid is down and obviously doing a good job to sort of pull it up. And you can see, and I think this happens when we do this in general, if we have like a MAC hole case and we're lifting the hyaloid, the hyaloid was lifted here, but there's some intraretinal hemorrhages that are out there. So here we're doing a good job really shaving to be able to look for anything. Has anyone on the panel experienced having any retinal tears in these settings?
I was just going to comment on the technique because I love this Will's video that I always used to show the fellows called the drunken walk maneuver. And basically it's where you're essentially going across the vessels in an angulated fashion. And
Do you mind pausing the video?
One of the nicest ways, I think, of lifting the hyaloid when you really are struggling with it. And I remember Will's put out the video a while ago, and it's really fantastic. But yeah, you have this happen. It's very difficult to determine. You have to really be meticulous about making sure every single bleeder is checked, and you just want to make sure you don't have anything there. And even when you're suspicious, sometimes you may actually even put some laser in prophylactically around those areas because you're concerned about bleeding. This is very peripheral retina. I wouldn't be too concerned about this patient.
So if you went in here, you lifted the hyaloid, and then you realized that there wasn't just a tear in the retina, but there was actually a tear with a fair amount of subretinal fluid, would that cause you to change your sort of approach at all? Sumit, if you encountered that where somebody ended up having an RD after you lifted hyaloid, what would you do?
So I think you'd want to fix the RD and not do the injection at that time because in a lot of the protocols actually may even specify that. But if it was me, I wouldn't inject the medication. Most likely I would fix the RD and then come back later potentially to do it. Or maybe that patient's not an ideal candidate for the study.
Carl, one of the things that you mentioned earlier was different techniques for doing the bleb. And what's your preferred technique for doing it? Any sort of pearls? Because obviously, you want to be able to sort of get this right, and it's a little different skill set than we sort of do on our standard OR days.
Yeah, first of all, placement, is per protocol. These are all investigational products we're talking about, right? So for the RGX program, we're now going inferior. We used to go superiorly, but some pigmentary changes in the periphery to help minimize that type of problem that could arise. We want it inferior and pretty far in the inferior periphery. But when you touch down, you're either going to do a direct subretinal injection or a pre-bleb. Those are the two basic approaches. I've done both types of approaches, again, with cell or gene therapy. I think just touching down, you do a little dimple, you see a little blanching, you start to inject a little bit, and if it looks like it's subretinal, great, you continue on. If you don't, you go someplace else. You just don't want to go sub-RPE. So I don't do the pre-bleb thing anymore.
Okay.
The only issue with the pre-bleb thing is that you create a small bleb, you go back in, and you end up with a larger hole, and some people are concerned there's going to be a spill out of product.
So maybe moving on to a different spot if that happens.
Yeah.
I see that there's a question in the audience.
Is there any role for
That is an excellent question, and I will be giving a talk later about IRD, and one of my co-moderators was fortunate enough to give me a video about that.
So I was one of the masked observers in the gyroscope studies, and they did those tube labs, right? So they had the tube labs that they did, and then they had the drug injection, which then, when they went to air, made them coalesce. Is that advantageous, or is that why the study might have failed, because it was too large? I mean, that was probably, is the most interesting surgeries to watch, because as you said, like, there were a lot of aborted procedures. There are a lot of procedures where they didn't realize the hyaloid wasn't elevated when they were trying to put the needle down, and they had to go back and then put down Kenalog and then re-elevate the hyaloid and stuff.
That's by far the most important aspect to all these programs. But there are different volumes for different products, anywhere from 150 microliters to 300, and sometimes, 300's big, so you might have to go in two different areas.
Awesome.
I think one of the problems with, say, the Avalanche study, and it could happen in this one too, Regenex, is that sometimes it does get injected under the RPE. So in this trial, I took a different approach. I started injecting right as I was about to touch down. That's the way we used to do the macular translocations. And you lose a little bit of the fluid, but you're going to do a fluid air exchange and take it out anyway. But that way, there's really no risk, in my opinion, of getting it subretinal, because you actually have this jet that blows a hole in the retina, and the retina just comes up to your needle. It's very easy to do. It's easier than touch down and making sure you're in the right spot. And maybe that's why I like it, because it was easier. But it's not as controlled with respect to losing some of the IP, and it may not be applicable for like cells where you don't want them to get in the vitreous area. But it's a little easier if right before you touch down, you step on the pedal, and it'll just blow right up into your syringe.
This has been a great discussion. Do you mind playing the video? So we were fortunate to get to a nice bleb that formed, obviously staying away from the macula as was being intended. Didn't need to do sort of multiple sort of blebs here. And so for these studies,
Blebs are always way bigger than you think they're going to be.
Yes, and they're gone the next day,
Yeah.
which is crazy to me. But yes, much bigger than you sort of would think. And then taking a really good look to make sure that there's nothing there. It's a little hard to see because it's right at the edge, but we noticed that there was a very small little tear right at the aura. So put some prophylactic laser surrounding that sort of area. And then as was mentioned sort of earlier, we do air fluid exchanges for these patients, and so that was done here. Awesome, great. So I think we covered these things. Great. Okay, so moving on to our next case. So this is a patient who's a monocular patient, a 75-year-old woman. She has decreased vision in her left eye over the past month. She unfortunately had trauma in her right eye as a child and has just count fingers vision in that eye. She's pseudophakic in the left eye. This is her OCT. She's 20/80. She's got a full thickness macular hole there. It's not necessarily a particularly big hole that's present, but the patient's really concerned once we explain to her about surgery, because she's had a history of multiple back and neck surgeries. She's really concerned about the ability to position after surgery. And not surprisingly, she's very, very anxious about surgery and this being fixed correctly because it's her only eye. So one of the questions that I had for you guys is, would you consider doing any sort of extra maneuvers in this patient beyond sort of our standard repair of a macular hole? How about you, Justice?
So, in this case, the biggest question for me is, given her positioning challenges, do you consider C3F8? I wouldn't, that's not that big of a hole. So anything, I usually do a relatively large ILM peel, but I wouldn't do any of the bottom four, because you're likely going to have good success getting that to close. One of the questions really comes down to these monocular patients is, what's their support system? How are they going to be? Are they alone? And it is this balance, because your goal is long-term success. And so those couple of months with C3F8, versus SF6, that to me is the biggest, decision here. But more than likely, you're probably going to be fine with SF6 with that size hole.
Okay, and would anybody else do anything differently? If you have someone who has a large hole, a chronic hole, or refractory, what are your sort of go-to ways of fixing it? If you attend retina conferences, it seems like there's this epidemic of holes that are unable to be fixed. Phoebe, how about you? What's your go-to?
For large primary holes, I'll do an ILM flap. I've not tried amniotic membrane or autologous graft. And then for recurrent holes, especially large recurrent holes that are stuck down at the edges, like flat open and recurrent, I might do the subretinal blebs. And then I've also done reflux kind of bleb, like through the hole itself, and that's worked nicely.
How about you, Dilsher? What are your go-tos?
Yeah, I do something similar. I do the ILM flap mainly. I'll massage the tissue around. I've done subretinal blebs as well, but I've not done amniotic membrane. And my partner does that, and he likes it. And the vision's still not great though.
But it looks beautiful if we orient
Exactly.
the OCT. If you're going to do an ILM flap, how do you do that? Like, what's your technique?
I generally do I'll do a wide peel and then I'll drape it over, and that usually works.
Awesome.
What's the actual size?
Of the hole?
Yeah, go back.
Small.
I didn't measure.
It doesn't look very big.
No, it's not that big.
This one was
Yeah, I mean, I think this is where, like,
Yeah.
the evidence says if it's above 650, most of the studies say that 600 or 650 is when you really want to do something that's the innermost. So this is just a tiny little hole. It's not that big a deal anyway.
Well, I'm glad that you guys think that this is a tiny little hole. Part of what we do at academic institutions is teach fellows. And some of what sometimes I think about doing, to your point, Dilsher, about like you wish that you had learned how to do certain things during fellowship, like drainage retinotomies, is making sure that our trainees feel comfortable doing some of these techniques so that then when they really need to do it in a high stress situation, that they're ready to go. And this was a nice example of an ILM flap, so I'm showing it to you.
I don't want to comment about the patient's anxious about position. I say,
Yeah,
don't
sure.
worry about it. In a standard hole, like this hole, which
Yeah.
is going to close even if there's no face down positioning. I say, don't worry about it. Just do your best. And I only recommend a couple days anyways for small, medium holes, maybe 3 days if it's large anyways. So.
Yeah, it's interesting how there's big differences in how long we tell people to position and based on sort of training and sort of what used to be done versus what's commonly done. But if you ask patients, they'll like Google and see that they have to position for 2 weeks or something. So if I'm doing
Some of them say a month.
I know,
Yeah.
it's crazy. So when I do an ILM flap, I usually do them pretty wide as well. I like using the flex loop. I think that's a really nice tool to be able to do that. I try not to do sort of any sort of hinge flaps because I think you run the risk of it sort of ripping off. So we use the flex loop to make a really nice, like sort of wide temporal flap. And then sort of just loosening up right up to the sort of edge of the break and then sort of continuing around to do sort of our nice peel. How many of you guys use the flex loop in general with your trainees? I know Justice does. Alexander, I think I didn't do it during fellowship very much, but I think it's a nice technique when people are learning. It's sometimes a little bit more predictable than some people will say, like pinching and peeling is pinching and praying. So,
Actually use it in the
Yeah.
refractory case that didn't close after an ILM peel. I use it to mobilize the macula.
to mobilize the edges. Some people use like a Tano scraper for much the
Yeah.
same way to be able
Flex
to
loop is
sort of mobilize it. So we just made sure that we did sort of a wide peel here to be able to do it. Has anyone had an ILM flap that's gotten truncated accidentally? I had one happen during fellowship that made me sad. And then just doing a good air fluid exchange here.
I saw
Slow
one flap.
air fluid exchange.
Was that?
It's a slow one, so you
Yes.
don't
Yeah,
aspirate
yeah.
it away. Because that's what it happens often.
Yes. Yeah, I skipped by. So you have to, when you're doing the air fluids, like really sort of tilt nasally to be able to get it to cover. Any pearls that you sort of talk to your fellows about, Sumit, as you're doing them, when you're doing the air fluid exchange for the flaps?
Yeah. So I tend to say just go really slow on the air fluid exchange. You have the eye, like you said, tilted away. I usually don't leave a flap that large. If I'm going to do it, I'll usually truncate it and make it a little smaller than that. But generally, when it's a little smaller, it's less likely to get aspirated away, especially if you're staying on the nasal side of the nerve.
I think it's also interesting looking at the flaps post-op. So you can kind of see it in your picture, and sometimes they can be quite pronounced. I actually had somebody refer to me for epiretinal membrane. There was a flap that somebody else created. And there's one patient I have, the flap, the hole closed, but the flap kind of migrated, so the patient can see it as a floater.
Interesting.
Yeah, so it's something to consider that, even though it's such a nice surgery, you might not necessarily use it for everybody if it's not needed.
Yeah, I saw one case where the flap actually flipped back over and opened the hole back up.
Oh, really?
Just in that local area as well.
Very interesting. So this is what she looked like post-op week 3. Vision's already improving, and you can see that her hole has closed, which is great. And then in the interest of time, I think we're going to leave it at those 2 cases.
Fantastic presentations. Thank you, everybody. We don't want to deprive you of a well-deserved break, so we are going to take 30 minutes. So we're going to come back exactly at 3:40, and you want to be here because it's Dr. Martin as the first talk of the next session. So we'll see you in 30 minutes.
Dr. Martin. Eyeball AI.
Eyeball AI. Sounds like Ebola or something. Okay.
Can I introduce you?
You can if you'd like.
Yeah.
Go ahead.
Okay. So next up we have the perfect chairman.
Okay, you get a raise now.
Raises all
Okay.
around.
My chance.
Okay.
All right. Dr. Martin is going to talk about current and planned trials in the DRCR Retina network.
All right. Thank you, Alexandra and Kat. You guys have been wonderful with this. So I'm going to cover in the next 10 minutes current and planned trials in the DRCR Retina network. There are a lot of them. So first of all, the network was formed in 2002 as the Diabetic Retinopathy Clinical Research Network, as I think all of you know. In 2017, the NIH allowed us to expand our scope to cover all retinal diseases. So now there's 2 chairs, myself and Jennifer Sun. And originally, Jenny was going to be the diabetes person. I was going to be the AMD and everything else person. The reality is we work so well together. We both do both of it, but we both do all of it, excuse me. But increasingly, she's doing more diabetes and I'm doing more of kind of everything else. Right now, we're running more clinical trials than we've ever had in our history. We're actually running 9 different studies, including 9 ongoing initiatives with collaborators across the world. I'm not going to cover all these. I don't have time to do that. I just picked out kind of the biggest 4, I think the 4 most important ones that we're currently involved in. So the first one is called Protocol AF, which is a randomized trial evaluating fenofibrate for prevention of diabetic retinopathy worsening. Fenofibrate's an old drug, been around for a long time to treat high cholesterol and triglycerides. There's already strong evidence from Accord and Field that fenofibrate reduces the rates of diabetic retinopathy working, yet nobody uses this. And it's possible that the reduction rates are substantial. Here's the data from Accord and Field. Do you guys know the Accord and Field studies? Most people don't. So the Accord study was a roughly 10,000 patient study of patients with type 2 diabetes looking at cardiovascular risk. They had 3 different parameters they looked at. That's glycemic control, hypertension, and lipid lowering. About 5,500 of the patients were part of the Accord lipid trial, randomly assigned to a statin plus minus fenofibrate. And when you looked at the 3-step rate of progression, it was substantially reduced, 5 versus 12%, with the addition of fenofibrate. When you look at the Field study, which also was looking at patients with type 2 diabetes, and there was a 2-step reduction with the use of fenofibrate, 3% versus 15%, or progression, excuse me. So pretty good data, but we don't use this, and it's really interesting why we don't. Actually, I don't have a great explanation, except that we like to inject things. We don't like to write prescriptions for pills. So bottom line is we're doing a 4+ year study that includes a placebo control group. which allows a number of ancillary studies, like, for example, looking at the GLP-1 receptor agonist and its effect on progression of diabetic retinopathy. Some other imaging studies will also be looking at continuous glucose monitoring. A lot of times we talk about the A1C. My prediction is in a few years, we're not going to be talking about A1C with the same frequency with which we do. It's going to be time in range, because so many people have gone to this continuous glucose monitoring. And it's really, so far from what we've seen, a better predictor than the A1C. This is the study design. It's 560 participants with basically mild to moderate diabetic retinopathy up to moderately severe. In at least one eye, randomly assigned to fenofibrate versus placebo. The primary outcomes proportion of eyes with diabetic retinopathy worsening over a 4-year period. This is basically AREDS for diabetes. Think of it that way. That's what this study is. And it'll be very interesting if we can see, even if we see a small risk reduction, it could be huge given the number of people with type 2 diabetes. Protocol AL. Arun Singh approached me with this idea now, 5 years ago, of using a sustained-release steroid to reduce the risk of progression of radiation retinopathy. After lots of, I think for over a year, every Wednesday night, for 2 hours, my protocol development committee was Carol Shields, Arun Singh, Tom Albrecht Jr., Prithvi Mithranjaya, and Amy Scheffler. And we sort of crafted this study, which is basically a randomized clinical trial looking at 600 eyes that have choroidal melanoma undergoing plaque brachytherapy. And we had to define the parameters. Who's at risk for developing radiation retinopathy? It turns out if you have 30 gray to the macula, that's the greatest risk. We also didn't want to include eyes that were going to be fried by the plaque, because sometimes in large tumors or very high doses to the macula, there's nothing to recover here. So the tumor can't be directly underneath the geometric center of the fovea. It can't touch the optic nerve. Patients are randomly assigned to faricimab versus Iluvien versus an observation arm. And the primary outcome is change in visual acuity over a 3-year period. Honestly, one of the more interesting things about this study is going to be all the secondaries. There's lots of secondary studies that are already layered into this thing. One of which is to look at sequential wide field angiography and create a DRSS score for radiation retinopathy. The diseases are very similar. Radiation retinopathy and diabetic retinopathy are similar. We just know when radiation retinopathy starts. And so this is the first randomized clinical trial ever in radiation retinopathy, and the first large one, and the first in choroidal melanoma in 35 years. Protocol AM is a randomized trial comparing immediate versus deferred surgery for symptomatic epiretinal membranes. It's a question we ask all the time. You have the patient who walks in the door who's got significant central subfield thickness, let's say it's 450, and their visual acuity is 20/30, 20/25. Do you operate on those eyes? And a lot of us don't. Some people do. The real question, though, is if you don't, does leaving the center of the fovea disturbed, altered by this epiretinal membrane, does that compromise long-term visual acuity outcome if this progresses and you wind up operating, say, 3 or 4 years later? So that's the question we're trying to answer. Early versus later surgery if you progress. And so this is the randomized clinical trial, 400 eyes, immediate surgery versus deferred surgery. Primary outcomes mean change in visual acuity, and from baseline to 36 months. We'll also be looking, we have a whole AI piece to this, collecting sequential OCTs on these patients, and we'll be looking for variables that predict progression, or those that predict, at least in the eyes that don't have surgery, or variables that predict visual acuity outcome in those who do. Okay, protocol AO is the last one I'm going to cover. Homo-CT guided treatment versus treat and extend for neovascular AMD. So, of course, I have to start with the cat slide, right? So there's tremendous variability in the number of injections, and several of the speakers have already addressed this. To me, this is one of the more interesting slides that came out of CAT. This is a plot of the number of injections over time for both ranibizumab and bevacizumab. I think all of us going into this assumed this would be a bell-shaped curve. It's not. It's flat. The number of people who need 24, 25, to 26 injections over a 2-year period is identical to the number of people who need 1, 2, or 3. Why is that? We don't know. I wrote so many negative papers on this topic. we looked at the genetics, we looked at everything you could think of. Here we combined data sets with IVAN and other larger pool. We looked at everything we tortured the data to try to make it confess. And there's simply no explanation as to why this variability exists. And even if you control for the individual features of the neovascularization, there's nothing that explains this. So the bottom line is that we're not going to figure this out. We need but we'd like to know, we'd like to be able to identify these patients ahead of time. And if we could do that, or if we had some sort of daily assessment of disease activity, it would allow for personalized treatment. So enter home OCT, and I think you all have heard a talk on this. I'll skip through this part very quickly. The device, it's self-image, patient self-image daily, takes less than a minute per eye. The quality of the scans is pretty close to SD-OCT, and is transmitted to the cloud. Basically, the patients aren't buying the devices. The retina specialist orders it. The company then delivers this to the patient's home. They're providing a service and sort of gets it set up in the patient's home. They image daily. The images are not seen by the patient. They're uploaded to the cloud, and there's AI software that basically quantitates the fluid and produces a dashboard like this. And I've played with this dashboard a lot. It's pretty incredible how much information is here. You can look at through every page every day if you wanted to. People's OCT. More importantly, you set it for various alerts to sort of tell you, what do you care about? When should I call this patient back in? Which is kind of the whole idea here. So the critical question is, what role is this thing going to have in our clinical practice? Can it reduce visit and treatment burden, at the same time maintain or improve visual acuity outcomes over a 1 or 2 year period? To do that, we need to do a large randomized clinical trial, but before we do that, we really had to do a feasibility study, and that was Protocol AK. This was a small consecutive case series of 14 patients with newly diagnosed neovascular AMD. They were treated for 6 months according to standard of care, and the OCT was running in the background. And I'm run out of time, so I'm going to just very quickly sort of skip through this and sort of hit the highlights. Bottom line is that patients had no problems doing this. We expected there to be a decay over time or a fatigue, and there wasn't. And that's identical to what both Jeff Heyer's study showed at 3 months and also Nat Lowenstein's study all showed. The patients, they can do this. They do it pretty well. The variability is just enormous. These are just the fluid curves over time per patient. Just confirming what we saw in CAT, there's just enormous heterogeneity here. And so what you'd really like to do is you'd really like to sort of tailor treatment to patients. So here's a couple of case examples that came from that study, which to me is just remarkable. So look at the first injection line. So the patient was seen then, and so they had 120 nanoliters of fluid. And had you seen the patient the next time, you'd have said, oh, now there's 100 nanoliters of fluid. So you'd say, well, they're a little bit better. There wasn't much change. But what you don't know is the patient went totally dry within 3 days afterwards and stayed dry. They just started to relapse earlier. So what I think this is going to do, it's going to push the boundaries of these limits of how frequently we inject. There's no reason in the world when that thing starts to go back up that we need to wait 28 days. At least I don't think so. So we're not in this study because we're not beholden to sort of standard issues. We're going to inject. You got to wait 21 days, but we're gonna go as early as we can. There's also a lot of noise. The RPE is really effective at drying small amounts of fluid, and there's clearly fluid present on some days, and the next day you look there and it's gone. The RPE does a pretty good job. So you can't just treat every little nugget of fluid. So we had to set a standard threshold, and it winds up being 10 nanoliters. And there's some people for whom this takes a long time for it to resolve. So this is the trial, 600 patients with newly diagnosed neovascular AMD. They're randomly assigned to treat and extend versus home OCT. We spent as much time designing the treat and extend part, trying to get agreement on what is treat and extend, because I guarantee you if I started this conversation, not one of you in this room is going to agree to what treat and extend actually is, because everybody makes it up as they go. And then all eyes are going to be treated with faricimab. And so, in summary, there's lots of DRCR studies underway. We're going to look at the role of fenofibrate. We're going to look at do anti-VEGF drugs or steroids have any impact on radiation retinopathy. We're going to hopefully learn if we should be doing early surgery or maybe we shouldn't in these patients with a symptomatic epiretinal membrane. And hopefully we're going to understand the role of home OCT in the management of neovascular AMD. Thank you very much.
Any questions for Dan from panel audience? So one question I have, we have a lot of trainees here. How do you think they can get involved in DRCR?
Oh, thank you so much for asking that question. So earlier in our fellow session, we were talking about sort of how do you learn to do these things. The network's a perfect place to do it. When you get out into practice, please join us. We have meetings, in-person meetings twice a year, and we have training workshops. We have a clinical trials workshop. We have biostatistics workshops. We have all kinds of stuff that it's not just going through what we're doing. It's also sort of trying to teach you how to do a clinical trial. And my role in the network now as chair, I will never chair another study. That's not my job. My job is to basically make sure that scientifically we're headed in the right direction. My job is to write a lot of this stuff. But early on, we draft in a young investigator or mid-career investigator and make them the protocol chair. And my job is to support that person. My real job is to grow the next generation of clinical trialists. That's a major, major thrust of the network. So if you're interested in this, come join us.
Thanks for that excellent talk. So next up, we have my co-chair, Alexander Rashaskai, who's going to be talking about GLP-1 RAs and diabetic retinopathy. Thank you so much.
Great, thank you, Kat. So first question to the panel, maybe by show of hands. Any of you do anything different if you see a patient on one of these drugs? Anybody changes anything? Justice?
Well, now we have two for surgery.
Surgery.
Yep.
So our anesthesia is now dictating that they come off the drug a week ahead of time because of the delayed gastric emptying risk.
Do y'all know about this? Do y'all know that this is? I bet they don't.
Who knows about this? Raise your hand.
The delayed gastric emptying. Do y'all know about that?
Do you want to tell
I
them
would
really
say
quick?
something because we have a number of trainees in the audience.
Okay.
Do you want to say something?
Okay, good.
Yeah, but what about in the clinic?
I haven't figured that out yet. It's interesting. I'm looking forward to your talk. So
Perfect. Well, let's because I think it's a very actually tricky question, and these are my disclosures. But we get messages and phone calls from our colleagues who say, this patient has severe diabetic retinopathy. I'm not going to start them on Ozempic, or should I start them on Ozempic? Also from patients, I've had patients who came to me and they said, they started me on this drug and then I saw the commercial and I self-stopped everything because I'm going to go blind. Mm-hmm. So I think there's a lot of information out there and it's hard to discern what's what. So this comes obviously from the label. This is the label for Ozempic that did show that in their study there was more events of diabetic retinopathy complications in patients who were treated with Ozempic. But the story is not clear at all. In fact, there's arguments that GLP-1 receptor agonism could prevent or arrest the development of diabetic retinopathy. Retinal neurodegeneration has been implicated in the pathogenesis of diabetic retinopathy, and GLP-1 receptor is expressed in retina. GLP-1 receptor agonist has been shown to produce neuroprotective effects in the nervous system. And also it's been shown that GLP-1 receptor agonists can exert anti-inflammatory effects that could be very relevant to chronic complication of diabetes. So when you think basic science, it's not conclusive. Clinical trial data is also not conclusive. When we look at the REWIND and LEADER trials, they showed that there was no association between GLP-1 receptor agonism and diabetic retinopathy. And of course, SUSTAIN-6 trial, which is resulted in that warning, suggested a higher risk of diabetic retinopathy compared with the placebo group. When we look at these clinical trials, the cardiovascular outcome trials, the way they were done was very interesting. You know, we're so used when we think about diabetic retinopathy and how we assess it, you know, with the clinical exam and fundus photography. But in these trials, it was not very standardized. The baseline prevalence of retinopathy was not reported in all trials. And the methods of assessing for diabetic retinopathy were different. Sometimes it was categorical yes, no. Sometimes it was retinal procedures. Only 2 trials utilized fundus photography or dilated fundoscopy. And this is an excerpt from Sustain 6, where it says that, in fact, dilation was not required. So, you know, it's really hard to then take these findings and see what do we do with them. So there is also large database studies that are not conclusive. If we start from the bottom, in 2014, there's 30 patients who developed or worsened diabetic retinopathy with significant improvement in glycemic control, and in 80% of those, they are improved with continued treatment. Then there's some that don't see any association between the drugs and increased diabetic retinopathy, and some that think that it might be due to hemoglobin A1C reduction, but maybe not the drug itself. And some of these are quite large studies. Another study with Trinetics with Karen, who I think is here, excellent paper, actually did show that there's higher risk of progression to PDR and DME in this class of drugs. And some other IRIS papers showed no worsening. So it's very confusing when we look at these data. So Julie, who's in the audience as well, was the one who helped me with this study. We wanted to look at the real patients, and we looked at almost 1,000 patients, either on GLP-1 receptor agonists or sodium glucose cotransporter 2 inhibitor, which is another class of newer drugs. And we wanted to be very inclusive and very clear in our outcomes. So we looked at clinical worsening by ICD-10 code and diabetic macular edema development, and we looked at the procedural worsening. And what we did after we did our pool, and when we identified worsening based on pool, we actually went and manually checked each time there was perceived worsening. So this is our patient demographics, and they're well matched. Of note, of course, GLP-1 receptor agonist users had a higher baseline BMI, and importantly, our baseline hemoglobin A1C was not that high in this patient. It was 8.2, which is lower than in some of the cardiovascular outcome trials. What we saw that there was no significant difference in clinical worsening. Interestingly, also in our cohort, the difference at 1 year between hemoglobin A1C between the 2 cohorts and within each cohort was not clinically significant. It didn't really change that much. So this is just showing all the clinical and procedural indications of diabetic retinopathy worsening, and we didn't see any association between GLP-1 receptor agonist and worsening after propensity score matching. So in our study, we showed that there is no difference in worsening of diabetic retinopathy in GLP-1 receptor agonists compared to SGLT2-1 inhibitor. What could be the cause of this? Well, it could be that we have a limited sample. Maybe it's such a rare event that looking at this number of patients is just not giving us the information. It could be that we didn't have enough semaglutide. Maybe there's something special with Ozempic as compared to other medications that's driving this. What I actually think is going on is our cohort was interesting. It was baseline hemoglobin A1C was quite lower for some reason. Must be having healthy diabetics in Cleveland, but it was lower for some reason than even in Sustain 6. Moreover, we didn't see this dramatic drop in hemoglobin A1C within our groups, which once again has been shown in other studies. So is it, the question becomes, is it the drug or is it the hemoglobin A1C change that's driving this potential worsening? The other interesting thing that I was thinking about is when, like I mentioned, when we initially did the pool for any worsening, we actually identified 126 cases of worsening. But when we manually reviewed them, only 24 of them were real. Majority of it was actually transition of care. So a patient was seen by an optometrist or a general ophthalmologist, was given a diagnosis of mild diabetic retinopathy. In a couple weeks, saw a retina specialist who said, well, actually, this is severe NPDR, and the diagnosis gets changed, right? And it's not because the retina specialist has more expertise or more imaging capabilities. But if you're just looking in the chart, right, if you're doing a large database study, that will show as worsening. So I think it's just something for us to keep in mind as we interpret the data that's out there. So I think ultimately it's very important to follow up patients who have dramatically improving glycemic control, and it's been shown before with insulin as well. And the other thing I think it's important, we talked today a lot about clinical trials, and there's a lot of trials looking at diabetic retinopathy severity. And if we think about, we're comparing two drugs, or we're comparing placebo to a drug in diabetic retinopathy severity, if our cohorts are not matched on the use of these drugs or change in hemoglobin A1C because of these drugs, we actually might be skewing our results. So it's just something for us to think as we look at the clinical trials. And there's an ongoing prospective study looking at the effects of GLP-1 receptor agonists on diabetic retinopathy. And I think that, ultimately will give us even more information. So I thank you, and I welcome any questions.
That was a really interesting talk, Alexandra. Did you guys look at any quantifiable characteristics like vision, CST, vitreous hemorrhage, things that you can quantify better?
So when we looked at the worsening, the most common worsening was vitreous hemorrhage. We didn't look at the CST changes in those patients. It might be interesting. There's actually, I think there's some thought that the other type of drug could actually be beneficial, in terms of diabetic macular edema, which would be interesting also to examine.
Alexandra, it's really interesting. I mean, for me, I feel like the benefits are so clear of these drugs that it's systemically that I haven't told anyone they should get off it. I've seen maybe one or two where I thought, was this related to it? I had one patient where they were much more resistant to anti-VEGF than I would have expected. Did you, when you looked at any of the complications, look at treatment response and if there was...
On these drugs, you mean?
When they were on these drugs, like if they developed diabetic macular edema, did you get a chance to look at that? Again, it's really small numbers, but...
No, but might be a next project.
Alec, I have a quick question for you. So I've had some patients who get on these drugs and then they can't find these drugs because they're hard to get. Then they get off these drugs and then they come back on these drugs. And the in-between period, sometime they're, I have a patient that was on it, was doing great. I was so proud of him, and he came back. I can't find the drug for 3 months, and he now had DME that he didn't have DME for a long time. So was there any thinking about that? What do you think? When we do these studies, are we looking at patients who are on it for a long time, who just started, who are off and on? They're going from, Ozempic to Mounjaro or Wegovy, and
right.
There's a lot of, I think these are already patients who have high A1C or high morbidity, and that's why they're on these drugs. And then they're not getting that consistent treatment because of the shortage.
No, I think it's fascinating. I mean, a lot of these patients, right, they're on so many other medications as well. There's a lot of polypharmacy, and then we didn't look at stopping and starting, but it's curious. I think I think also it would be really interesting to look at patients starting at different time points, right? So if you have very minimal disease, could be actually protective if you started earlier, right? If you catch it early, but it goes back to some other discussions of biomarkers and how do you assess those patients who actually in early stages of the disease, and if they're disease modifying in some way. So I think there's a lot to be learned about these drugs and diabetes.
Great talk, Alexandra, and great discussion. So next up we have Dr. Regillo, who's going to be talking about novel treatments for DR and diabetic macular edema. Thanks so much, Carl.
Thanks, Kat, and thanks to the organizing committee for the invitation. It's been a great meeting. I thank you.
I think you just click next, yeah.
Oh, there we go, great. So very rich, exciting space to be in, retina in general, but also still diabetic macular edema and diabetic retinopathy, and that's what I'll be covering in a quick 10 minutes, a lot of data. Financial disclosures are here. And everyone's aware, this is diabetic macular edema, but I'll be covering both DME and the potential future of DR. But for DME, center-involved DME, of course, it's all about anti-VEGF therapy. As first-line therapy, it works very well, very safe, and yet we also have other treatments. And as you'll see, the pipeline is rich for even more. For diabetic retinopathy, NPDR without DME, the standard of care for the most part is still watch and wait. We don't routinely treat that. So for what's new and emerging, well, you can see under new second-generation anti-VEGF agents, I'm not going to be talking bevacizumab. It did show some benefits, and that's what puts it into this second generation, but the safety profile didn't hold up as well as what we were using or what we now have. Faricimab, high-dose aflibercept, recently approved. I'll go into that. KSI 301 and the newer KSI 501. We'll talk about PDS and gene therapy. It's already been touched upon, so there's a lot of overlap with neovascular AMD. And then truly novel different MOAs. Again, also being used for wet AMD or in some just DR, DME. Faricimab, everyone's familiar with this. FDA approved now, about 2 years in our hands. This is unique in that it is dual MOA. It has not only the anti-VEGF-A arm, it has that angiopoietin-2 binding arm, and so that's what makes it unique. And of course, the clinical trial, the phase 3 clinical trial in DME, was designed to test against the standard of care, which is every other month aflibercept, and the two arms with faricimab both showed to be non-inferior, essentially work as well in terms of improving BCVA and mostly treatment-naive DME, as shown here, through the primary endpoint 1 year and into 2 years. So is it have any advantage? Well, yeah, when you start to look at anatomical results, you do see mean decrease in center subfield thickness here does favor, in fact, was statistically significant, favoring both faricimab arms compared to aflibercept standard dose. And indeed, when you look at proportion of patients that were dry, that didn't have intraretinal fluid, throughout the entire study, it did favor both faricimab arms, as shown here. And I think this is probably the most meaningful data for, what's added value. The added value here is that it dries better, it dries faster, and with less treatment. So that's what you have, and now you can see why it's getting some good uptake in clinical practice. And this is the durability part, and it's showing evidence for some degree of extended durability. We can't say how much for sure, but you can see up over 75% are being dosed by the end of the study, 2 years, at every 12 weeks or more, and high percentage, 65% every 16 weeks. So, and that's what you're getting even better drying, and with a good safety profile. So that's why you're seeing a good amount of use in practice at this time. As you can see, the IOI rates and all the AEs were similar with aflibercept. What about high-dose aflibercept? And of course, this was compared to standard dose. And in this clinical trial, the Photon for DME, very similar to the wet AMD trial, looked at 2 different regimens, up to 12 weeks and up to even 16 weeks of extension into the maintenance phase of the quadruple 8 milligrams aflibercept. And of course, it met its non-inferiority endpoint in terms of BCVA improvement through the primary endpoint at 48 weeks, as shown here. And it did show a very strong signal for extended durability, and quite very impressive. You're talking about 90% of patients going every 12 weeks to 16 weeks, as shown here, with 8 milligrams. This is through the primary endpoint. Excellent safety profile, no different than the standard dose, so that panned out very well. And now all this is holding up through 2 years. This was FDA approved last year, and recent J-code, you're going to start to see, I think, quite an uptick in utilization of this drug, too, for DME. What about the port delivery system? Rishi had a nice summary of all this, of course, in wet AMD. This is FDA approved, albeit on hold, FDA approved for neovascular AMD. It's high concentration ranibizumab, diffusing out through this surgically implanted reservoir. You can see the neovascular AMD trials, both the US-based Archway, which led to FDA approval here, and the studies abroad looking to expand approval elsewhere. but it's been on hold because of the septum dislodgement problem. It was on hold for both commercial devices in wet AMD and for clinical trials, but that has now changed. But before it was put on hold, it did go through the DR-DME studies, Pagoda and Pavilion. What did they show? This is the DME study with the port delivery system. Both arms had initial loading of anti-VEGF, and then the port implanted and then refilled every 6 months compared to monthly ranibizumab at 0.5 milligrams. And it showed great results. It worked as well as monthly ranibizumab, even at the higher dose that's used ex-US. Look at the drying with the OCT, identical. Okay, so sustained delivery works very well. In fact, the safety profile, we know there are issues with having device and surgery and the safety. Rishi showed that earlier. But we're seeing trends for better safety outcomes as we progress along through the clinical trials, including these DME studies. As you see, no cases of endophthalmitis in the Pagoda study. And the Pavilion study looked at putting the port compared to observation for DR without DME, moderately or severe NPDR. And how did this study? This was actually refilled at 9 months rather than 6 months. It showed really excellent improvement. 2 or more step improvement in DRSS was up at 80% at the primary endpoint. So sustained delivery in this way with ranibizumab through the port works really well to improve diabetic retinopathy. And again, a trend for some better safety as we progress through these study results. And now, as Rishi showed, with the implant modification and refill needle changes, this is now back in clinical trials. We expect this to be available in practice within a year once the FDA writes off on this, and the company will be applying for FDA approval in DR and DME. Gene therapy has already been mentioned. There are 3 gene therapy programs. The RGX is subretinal and suprachoroidal. It's the suprachoroidal approach that's being tested for diabetic retinopathy. ADVM and 4D-150 are intravitreal gene therapies. Again, this is all to produce VEGF-A protein inhibitors. And the 4D-150 has a DME study. I'm just going to briefly show you the suprachoroidal RGX program because that's what we have data on. But this is for moderately severe or severe DR, NPDR. And we have 2 dose cohorts to show some data at 1 year. And it is showing suggestion here that, as you would expect, for gene therapy to produce what is in essence ranibizumab, we're seeing percentage or proportion of patients improving in their DRSS, and no patients are worsening out through 1 year in this study thus far. And also relatively well tolerated for the suprachoroidal approach. So we're going to hear more about that for sure. What about tyrosine kinase inhibitors? This is sort of an indirect or intracellular VEGF blockade-like approach. These are small molecules packaged in either bioerodible intravitreal implants, also packaged as suspensions that can be delivered suprachoroidally. And there's even now also a drop in clinical trials for DR and DME. I can tell you, all of the programs are showing some benefits that are anti-VEGF-like in the setting of neovascular AMD, and we just had a press release with Ocular Therapeutics with regards to some favorable data of decreasing DR progression in a very small DR study. Just for something completely different, KSI 301 is the anti-VEGF-A large biopolymer that's being tested in DR without DME. It failed in wet AMD, but the same company has KSI 501, which is this large monster, as you see, which is a VEGF trap, so it works like aflibercept, but also has IL-6 inhibition, and this is being used in DME. And so far, we have this very small DME study that looks promising in terms of getting a typical effect that seems to last beyond that 3-injection loading phase for about 4 months more. So that's also moving along. And then for something very different mechanistically, REF1 inhibitors is an oral small molecule that's being tested for diabetic retinopathy. By this pathway, you can expect sort of upstream benefits of decreasing VEGF and also inflammatory cytokines, as shown here. This was tested, again, orally a BID dosing in the Zeta-1 phase 2 study looking at DR. The primary endpoint was 2 or more step progression in one eye, the study eye. It didn't meet that primary endpoint, but reanalysis of the data showed that when you sort of like the Accord study, when you factor in both eyes, looking at a total of 3 steps or more worsening, you can see there were some favorable results for patients that got the drug, and we expect this to be moving forward. I don't have to talk about this one much. This was a topical integrin inhibitor that went through the phase 2 DREAM study and just recently showed no benefit. So that we're not going to see going forward. And then dexamethasone, we know steroids work very well in DME and may even have some benefits for DR, but this is an eye drop. It's a high concentration, specially formulated eye drop of dexamethasone that's showing some intriguing benefits in DME, with improvement to vision and decrease in central subfield thickness after 6 and 12 weeks of administration. And this is progressing into stage 2 of the larger phase 2/3 Diamond study. And then last here were some recent data that came to the podium at Angiogenesis with Restoret. This is EYE-103. Again, a very unique molecule, a tetravalent trispecific antibody that acts as an agonist, a Wnt agonist. A pathway that's well established, but in our space, probably not very well known. At least I didn't know much about it. But it basically acts as a neuron mimetic that in turn will stimulate or activate the Wnt pathway, which is involved in vascular stability. And the proof is in the pudding. It was injected intravitreally in the small phase 1/2 study, the Amaron study, and it showed very good VEGF inhibition-like effects that we're used to seeing. In fact, very impressive anecdotes as shown here with 3 intravitreal injections showing excellent drying in DME. So the future is very bright. The pipeline is very rich for both DR and DME. We've got good, well-established anti-VEGF therapeutics that are only getting better with the second-generation agents that we now have in our hands and potentially others to follow. And we have sustained delivery, which I've always been a big fan of, and I think could do very well in this space, not only wet AMD, but for DR and DME with PDS, with gene therapy, with TKIs, and then a variety of very novel molecules that we're going to see come to larger scale studies very soon. Thank you very much.
Any questions from the group?
What?
Oh, yes.
Role of laser.
It all comes full circle.
Well, that one slide, laser was pretty far down on the list, but it still occasionally gets used, certainly focal laser for DME, occasionally, right? Probably third line for most people. I have to say, it's been a long time since I've done focal laser for DME, but we still use PRP, that's for sure. Did a couple PRPs last week, Used to do them every day, but now I did a couple the other week. So yeah, for PDR, PRP still certainly has a good role.
Wonderful. Thank you. Thank you, Carl. Next up, we have Sumit Sharma talking about surgical management of complicated macular holes, not like the one that Kat was showing. Hey.
Thank you. Thanks for having me. I'll wait for my slides.
Just click next.
Oh, okay, great. So my disclosures are listed, none are relevant to this talk. So when we talk about full thickness macular holes, we don't really talk about the spontaneous closure rate, but a small portion of these, 4 to 11% in the literature, can actually close, especially if they're less than 250 microns. But you have to wait up to 6 months to see that closure. And this paper that looked back at a meta-analysis in 2019, looking back, found that up to 1 in 10 of these smaller holes can close. If they have a bridging membrane, they're more likely to close. And if they have a little bit of traction still remaining, when that traction relieves itself, they are also likely to close. But then primary closure rate with ILM peeling is like 90 to 97%. I think somebody mentioned it earlier. You go to these talks, you go to the conferences, and people talk about it as if there's this epidemic of non-closing macular holes, but the primary closure rate is very, very good. And it's greater for smaller holes when there's a shorter duration that they've been there for, when you use gas. And most interestingly, because we were talking about this a little earlier, plus or minus with face-down positioning. There was a meta-analysis in a Cochrane review that came out just recently, last last year that looked at all the studies that are out there in the literature in terms of face down positioning and did not find a benefit, a definitive benefit for face down positioning. But if you look at the PAT survey, the vast majority of physicians in the US, 95%, still recommend at least some level of face down, whether it's 1 day, 3 days, 5 days. Some are longer, but for most of us, we're still recommending at least some face down positioning. And what happens when you close them? Well, you can get one of these two outcomes, which are both good outcomes where the hole is closed, you've got some resolution of the foveal contour. On the left there, you actually have nice restoration of the ellipsoid zone compared to the right, where there is an absence of the ellipsoid zone, but that's still a successful anatomic procedure. But then you can also have a refractory hole where it didn't close with surgery, or a flat open, this type 2 closure type appearance on the bottom right. So what do you do when we have somebody who has a refractory to primary repair, or a very large hole like in the background here, or a super high myope, or sometimes when you can see these in association with a retinal detachment, and how do you really manage these? So there's a few different techniques that you can look at. You can look at scaffold-based techniques, which include the ILM flapper graft, includes autologous retinal transplants, and then or putting some other material underneath the retina to give a scaffold for that hole to close, either amniotic membrane or autologous lens capsule that's taken and brought over. But then there's manipulation-based techniques with either mobilization of the whole edges or doing these subretinal blebs, and there's a couple different ways to do each of these things. So for the inverted ILM flap, there's multiple ways. Kat showed one where you can leave a very, very large flap. I tend to truncate the flap in comparison. And there was a number of papers that came out over the last really, it started around 2008 and then kept going through like 2014, 2015, 16, 17, where the inverted ILM flap was kind of the big thing and everyone was doing it. And here you can see you can actually truncate that with the cutter. You just have to be really, really careful that you don't take off the whole thing, which can happen very, very easily. But in this case, the fellow did a very good job. And when you go to the air fluid exchange, there's still a nice amount. And we'll see intraoperative OCT shows that that flap is still attached and that there's a nice little scaffold for the hole to close around. And you can really see nicely with the intraoperative OCT, the flap there. You go very slow, gentle air fluid exchange on the nasal side of the nerve, and you leave the flap in position. And there's a number of techniques that have been described. I think, keeping your normal surgical techniques, making sure the posterior highlight is off, use steroid staining, stain the ILM, use either trypan or brilliant blue, and then there's multiple techniques described for the shape and the position of the ILM flap. This is the Swift technique, or this superior wide-based ILM flap technique, where you take a large superior flap and you fold it over, and then when you do your air fluid exchange, that flap just sits over. There's descriptions of using viscoelastics or fluorocarbon to keep that flap in position. But all of them are trying to do is to increase your closure rate for these holes that are less likely to close. So in general, more than 600, 650 microns, or that they're refractory to the primary surgical procedure. And in this paper looked at this in 2018 of looking at either putting in the ILM material into the hole or using the inverted flap. And the inverted flap overall had a little bit better recovery of the outer retinal layers, had a little bit of better recovery of the external limiting membrane, and the foveal shape and discoloration was better with the inverted flap technique. Now, there's always going to be complications, and some of these were mentioned earlier by the panelists, but what that flap really does is it probably provides some type of scaffolding that allows closure of these larger holes and prevents them from opening back up. Well, what if you don't have any ILM because you've already had a very, very large peel and you've not got any posterior capsule? Because this is what happened to Dilraj Grewal and Tamer Mahmood in 2016, and they came up with this technique on the fly in a patient that they were trying to figure out how to close this hole. This is like a 5th or 6th re-op, and what they ended up doing is actually taking a large piece of autologous retina. So they put in PFO, mark off with diathermy the area of the retina that needs to be removed, use vertical scissors to really cut out that flap, and then apply a broad base of laser around the edges of the flap. This was, I think, the very first video that they did. And under PFO, actually translocate that flap, that autologous retina, into the macular hole or over top of the macular hole. And then in this case, they did a direct oil exchange. But in terms of what it's potentially doing is that you're getting some neurosensory tissue, and that there may be some synaptic plasticity and ectopic synaptogenesis, and then maybe you're actually getting some structural and functional rehabilitation in this eyes. What's interesting is that they've now looked back and shown that there is some secondary vascularization of that autologous flap, and on OCTA, you can actually see some flow within the retina in about a third of these eyes after the autologous retinal transplant. Reasons these can fail to close can be, even though you anatomically have the flap in position in the vast majority in this study, you can either have the flap migrate or the flap retract, and you still end up with an opening. And there's other complications. You have a risk of retinal detachment, vitreous hemorrhage, epiretinal membrane over the harvest site. Luckily, they didn't see any endophthalmitis or suprachoroidal hemorrhages and no cases of CNB in their series. I'm curious, has anyone on the panel done one of these? I think Rishi, you've done one.
I have. It's horrible. It is the most difficult thing to work under PFO.
Yeah.
Dragging it, you never know where you are from a depth perspective.
Yeah.
The first one I had, I lost. Just sucked it up and lost it. The second one I had, it was upside down, like it was like curled on the retina, so I had to take the flex loop and actually lay it kind of flatter, and I think I caused some bleeding around the macula, which might be serum, so I guess that's good. But it was very difficult. It's very challenging.
Yeah. And I think that's the thing that most people talk about. Readjusting under PFO is actually very, very difficult. Getting a new graft, then you're making multiple holes in the retina. You can end up with subretinal perfluorocarbon. And if they have a large posterior staphyloma, it can be really difficult too. So another techniques that have been described are getting some other type of material, either amniotic membrane, lens capsule graft, serum, or plasma, taking some blood and actually putting it on the macular hole just to give some type of a scaffold. So this is a case with a very large hole that's been refractory to closure, and you can actually see that amniotic membrane underneath the retina there on the closed image underneath, in the middle image, and you can actually see that there's a nice closure with the return of the foveal contour. And this is pre-op. This is using that flex loop, actually punching out an amniograft with just a punch that gives you a nice round 1 millimeter graft, taking that graft and then putting it into the eye using a set of forceps and then actually placing it subretinally under the macular hole. And I have not personally done this technique. This is a video's courtesy of others, but they get closure, but sometimes it's just anatomic success and you're not actually getting any visual acuity improvement. So I question the utility of this. I have done the manipulation-based techniques with creating subretinal blebs, and these can be done in two different ways. One is the way I'm going to show, and we'll describe the other one, but what this does is it allows mobilization of the whole edges to maybe try to bring them closer, and it's the same thing. This one is with PFO to stabilize to prevent it from coming through the hole, but I've done it without most recently. But this is nice because it's got the live the video of the intraoperative OCT with a swept source intraoperative OCT showing actually the blebs forming. And since this time, I've done it without the PFO. But what's interesting is you often end up with RPE atrophy in the area of where you created the subretinal blebs. So this eye had 4 created, and you have in the bottom right on the FAF, you can see even though the hole closed, it's very atrophic appearing retina, and there's these multiple areas of complete atrophy associated with it. At the end of the video, you saw the flex loop kind of massaging the edges of the hole. So I've used that technique. And then there's a description of just once you peel the ILM, you can actually use just reflux on your soft tip to create the blebs, that it's a gentler way of creating the blebs. I have not seen FAF images after that. Phoebe, you mentioned you've done this.
Yeah.
Have you done FAF after on that patient?
No, I mean, I haven't regularly done FAF. There are several patients that I've done that on where it was successful. But
I've used
their
it
vision
for
improved
closure
too.
and vision gets better, but I didn't look at the FAF either.
Yeah,
so
that'd be good to
it's
look
curious
at.
to look going forward.
Yeah.
And then the most difficult ones sometimes can be the cases where you have a retinal detachment with a macular hole. What you don't want to do is what's done here, where you're injecting in the ICG and it's going subretinal because the retina is detached and that hole is wide open and the ICG is just all going subretinally. That's a bad idea. So you can use either dilute brilliant blue, because the thought is that ICG can be toxic to the photoreceptors and going subretinal wouldn't be great, or You can use a little bubble of PFO to protect the hole, put in your ICG, let it stain the retina, and then once it's nicely stained, you can remove it and then use the PFO almost as a helping hand to hold the retina in place to at least initiate your flap. When I do this, in this case, we actually ended up then taking out the PFO once we had a little bit of that flap initiated, because this retina was very, very floppy, as you can see. And this can be very, very challenging, peeling a detached retina. And this is one of our fellows doing a great job kind of initiating this. And then we end up taking out the PFO bubble. And you don't want to have it too small of a bubble, because if you have too small, there's a risk that it could go subretinal through the hole as well. So you just have to be cautious. There's a number of things to think about. But then she does a very nice job of getting the rest of the ILM off. And it's just, you want to be very patient. People talk about, I think you were talking about in the fellows panel, that people show their peels and make it look great. This was probably about 20 minutes total. So this is not, this is real speed, but this is not all the attempts to actually get the membrane off. But it came off very nicely, and this hole ended up closing. So thank you.
So the one thing I'd add on the concurrent holes in RDs, I actually think that if you don't have PVR, a lot of them will close without doing anything. So a lot of times I won't actually peel ILM unless there's PVR that's there.
I'll do it when there's pretty dense PVR, and this lady had lots of PVR.
I think Karen Way has a question.
No. So I tend not to drain through the hole, because there's data that there's worse visual acuity outcomes if you drain through the hole. So drain through a peripheral break, or we already had PFO open, so we put PFO in and drained through the peripheral break. No, not in that case. But otherwise, if I didn't have it, if the primary break was the hole, I would do a retinotomy.
One more. 2 questions.
But when there's PVR, it's a little difficult. Then you can't always use that technique.
One more question.
So no, I've only done one when I was a fellow, and I haven't done one since. I think in Japan they have a much more experience of doing that.
Sumit, I had a quick question. What about primary MACTEL-associated holes? What is your technique? Because those are hard to close without doing something else.
Yeah, you usually need something else. You either need, I've had some success using the ILM flap, thankfully, and I haven't had one that had needed more than that, but I tend to use a flap as a primary technique in those. Anybody else?
I think we all have like N of one.
Yeah,
you know?
I've done 2. I've done 2, and that's been great.
Yeah, actually, yeah.
I try and-
50% success rate.
Yeah.
I try and have a long conversation if it's worth trying to fix. in the
Oh,
patient.
absolutely.
Right.
Yeah, expectation management's critical.
Yeah.
Fantastic. We're going to move on to another talk by Dr. Talcott talking about the IRD update.
Awesome. Thank you so much. So probably the most important disclosure is that I am not an IRD specialist. And there's lots of stuff in development, so my apologies if I left anything out. So IRDs are, I think, are a really exciting space in terms of therapy development. Similar to sort of the epidemic of complicated macular holes and how to fix those at conferences, I feel like the IRD space used to be a session that was often reserved for like, Saturday morning, but there's so much development in this space and exciting stuff. So there have been really significant advances in our understanding of the genetic basis of IRDs, and so this has really positioned the field well to sort of have better treatment options. Luxturna was approved in 2017, and there's really now a number of ongoing clinical trials that could lead to further approvals of other medicines over the next few years. But our treatment approach to IRDs is really sort of twofold, and we really need a variety of different treatment options for patients with IRDs, because patients may seek care at different times and different stages of their disease. So early in the course, you want an approach where you're trying to prevent the retina and outer retina from actually dying. So pharmacotherapies should be sort of modulated and sort of geared towards either replacing sort of the missing protein as a potential treatment. But later in the disease course, after the outer retina has had changes, patient is going to have poor vision. And so you need a different approach that would actually help to restore visual function instead of just correcting the protein that's missing. So this is where other sort of approaches like optogenetic stem cell therapy or retinal prosthesis are really important in being investigated. So what I'm going to do is first talk about sort of therapies sort of grouping by disease, and this is really meant to sort of be high level talk, and then I'll be talking about some of those other approaches where you're talking about like restoring visual function. So we'll start with retinitis pigmentosa. MGT009 is subretinal gene therapy with AAV vector targeting loss of function mutations in the RPGR gene. There was a phase 1/2 trial that compared subretinal injections of low, intermediate, and high doses in X-linked RP patients. And actually patients in the lower two cohorts, not the higher dose cohort, were actually demonstrated to have improved retinal sensitivity and functional vision at 1 year. And based on this, the phase 3 Lumius study is underway and recruiting 96 patients. And so this just highlights that in those low and intermediate dose patients, there's actually significant improvement in perimetry and microperimetry for those patients. Another agent in development is AGTC-501, which is an AAV2 capsid delivered subretinally, also targeting the RPGR gene function in patients with X-linked RP. And the phase 1 Skyline study included 29 patients with X-linked RP. The first 9 patients were treated in the periphery for safety, and then the subsequent doses, patients were treated centrally. Microperimetry sensitivity was improved at 1 year for all those patients in the sort of who were treated later who had central dosing. And the phase 2/3 VISTA study is planned for 63 patients to either get randomized to the low or high dose of AGTC-501 or control. This is a video of Dr. Ratcheskaya looking at doing her treatment centrally in this patient. And there was a comment earlier about why don't we do intraoperative OCT for these patients. And I think it's really useful for these patients, especially if we're treating sort of centrally, to be able to see, to make sure that you're in the right space, so subretinal, but not under the RP. And you can see how that blood really sort of expands nicely there as she's injecting. These are some other things in the RP pipeline. So there's BIIB112, which is designed to rescue RPGR function as well using viral particles. And it's also given underneath the retina. And that's being examined in the phase 1/2 Xeria studies, where the primary endpoint was actually not met looking at microperimetry, but there were positive trends seen in low luminance visual acuity. And so based on that, they're moving forward with the phase 3 Solstice trial. The following are 3 other agents that are being examined in phase 1 and 2 trials as well for RP. So let's talk next about Stargardt disease. As a reminder, and I know we have some trainees in the audience, this is autosomal recessive condition caused by variants in the ABCA4 gene, causing accumulations of toxic vitamin A byproducts and photoreceptor outer segments. And so gildaretinol is actually a modified form of vitamin A that's given very attractively as an oral medication, and it's designed to replace the natural vitamin A with a form that creates dimers more slowly. So they've examined this in the various TEASE studies. So TEASE-1 looked at 50 patients with Stargardt's and found that this was actually slowed the rate of atrophic retinal lesions by 21% over 2 years compared to an untreated arm. You can, sorry, let me go back here, and that there's multiple studies going on looking at other, so the TEASE-3 study is looking at early stage Stargardt, that's ongoing. ACP is also being examined in Stargardt as well, and this is currently in phase 2. We know more about this medication, and we'll hear a little bit more about that in our next session. So we also have Usher syndrome, where there's other things being developed for as well. This is caused by variants in the USH2A gene that encodes usherin, which is produced in the inner ear and retina. The QR421A is an antisense oligonucleotide that includes skipping exon 13, leading to a more functional version of usherin that's given by an injection into the vitreous. The Stellar phase 1/2 trial demonstrated improvements in vision and retinal sensitivity, which was exciting. And so the phase 2/3 Celeste and Sirius studies are set to enroll 100 adult patients with the appropriate variants of the USH2A gene targeted by the therapy. There's also therapies in other indications. So for X-linked retinoschisis, ATSN 201 is going to be examined in a phase 1 and 2 trial caused by mutations in RS1, and choroideremia 4D110 is being examined as well. So changing gears a little bit, what do we do when patients sort of have advanced retinal conditions? One of the things looking at this is the approach might be to focus on sort of restoring vision as opposed to slowing tissue loss. So as we know, Argus was approved for this purpose, but like production was discontinued in 2020. And so the thought of this sort of optogenetics is to use exogenous photosensitive proteins, or opsins, to be able to really manipulate neural activity in response to light. And this can be used to make sort of bipolar or ganglion cells sensitive to light and bypassing sort of the non-functional photoreceptor cells. And so this can be used for sort of a variety of IRDs rather than specific ones caused by specific problems. So several companies have launched clinical trials to be able to examine this, if vision can be restored in sort of end-stage RP or Stargardt patients. So this is MCO 10 from Nanoscope, which really targets opsin expression to bipolar cells. One of the things that's, I think, particularly attractive about this agent is that the therapy is designed to be sufficiently active at ambient light levels, so you actually don't need any specialized hardware, as we'll see some other products need, to be able to project the images to the retina. And so this is given by an injection to the eye, and you can see what the projected vision for a patient might be afterwards. So there's a phase 1/2 clinical trial that recruited 12 patients with advanced RP and demonstrated safety of this. And 9 of those patients actually had improvements in luminance levels in vision on a guided maze, as well as or had a change in their visual acuity. The separate phase 2 STORE study also demonstrated similar improvements. So there's another phase 2 Starlight study that's being ongoingly investigated for Stargardts. And some of the data from the RESTORE study is seen here. Another agent that's being investigated is GS030, which combines an AAV-based gene therapy with the use of light-stimulating goggles for the treatment of sort of end-stage RP. This was examined in the phase 1/2 Pioneer study, where 9 patients who got a single injection then were trained with the goggles 8 weeks after the injections. And some of the preliminary data of patients who got the highest dose of the injection, that patients with LP vision could actually locate and count objects better than they could beforehand. And so this trial will continue with 4 years of follow-up, and there's an extension study going on. And then this is BS1, which is made by Bionic Sight, which is a recombinant AAV vector that expresses an enhanced light-sensitive channel for the treatment of RP. And they are recruiting 20 patients in a phase 1/2 dose escalation study. But they noted that the top 4 patients with the highest dose have been able to identify objects better. So in conclusion, there's really a number of clinical trials aimed at preserving or restoring vision for patients who have IRDs, and this has really exploded in the past couple of years. As more therapeutic options become available, I think there's a lot of different sort of treatment opportunities that should be included in our sort of standard approach to these patients. And options should really be geared towards where patients are in their disease course and what their genetic problem is. Thank you so much.
So that was quite tour de force.
All the IRDs.
All the IRDs. Any questions? I was just curious, how do you envision, most of the retina specialists, as you mentioned, are not IRD specialists, and IRDs, depending on where you practice, are seen by a variety of people. So how do you see if there's more approvals, how do you see that being incorporated into a retina practice?
I think it's hard to imagine how some of these therapies would be easily integrated into sort of, if you have sort of a smaller retina practice, because there's a lot of support that needs to come along with this. I mean, one of the things that's really beneficial is genetic testing is so much more available than it used to be. So I think that's the first easy step to do. But some of these therapies, to be honest, patients need to be sort of monitored very closely. And if you're looking at sort of these like vision restoration things, there's training that needs to be involved. So there's really a lot of support. So you really need a good team in place to be able to do that. As I'm sure when you were doing the Argus back, you need a team really to support this. So I think just getting started though with genetic testing is an easy way to get started, but it's going to definitely require more coordination than we sort of than we're used to before.
Great. Thank you. Wonderful talk, and so many wonderful talks and discussions that we're really running a little bit behind, and we want to make sure that our next session gets all the attention that it deserves. So we decided to take a break now, and we're going to come back at 5 o'clock for Dr. Dude's presentation. So we have about 16 minutes. We'll see you guys at 5.
Okay, thank you all. We're going to get started here. It's my pleasure to present an update on pegcetacoplan for the treatment of geographic atrophy. These are my financial disclosures of note. I'm a consultant for both Alimera and Iveric. And so let's start first with the mechanism of action. So it's important to know that pegcetacoplan is not a biologic. It is a synthetic peptide. It's a bicyclic peptide. You can see in this diagram here, you have 2 cyclic peptides, 15 amino acids each, and they are linked together by a polyethylene glycol PEG in the center. Its mechanism of action is to block C3 and C3b. Recall C3 is a central protein in the complement system. All 3 of the pathways converge on C3, and C3 is cleaved by C3A by C3 convertase to C3A and C3b. Pegcetacoplan also binds C3b and blocks all the activity downstream, including C5. By doing this, it regulates complement, so decreases inflammation, cell membrane destruction, and phagocytosis. Pegcetacoplan was FDA approved in February of 2023, and so let's talk about the journey to approval into the present. So first, I want to note that GA lesion location affects the growth rate. This is a very important principle, right? We know that non-subfoveal geographic atrophy grows more rapidly than subfoveal GA, and so if you're looking at clinical trials for GA, you have to consider which patients are in the trial. In the Oaks and Derby, 1/3 of the patients were non-subfoveal, and 2/3 of the patients were subfoveal, and subfoveal was defined as involvement of the foveal center point. You see 2 examples of patients here. The phase 2 is where this journey begins. This was a phase 2 trial. 246 patients were enrolled. Patients were randomized to pegcetacoplan monthly or every other month or sham. And you can see the primary endpoint at 12 months. We saw a 29% reduction in GA atrophy growth in the monthly group, 20% in the every other month group. These differences were continued on through the 18-month data. The story continues on to the Oaks and Derby, which are the pivotal phase 3 trials. These were very large trials, 1,258 patients. And here you see the key baseline characteristics of the population. I'll point out a few. The mean GA lesion size is approximately 8.3 millimeters squared. You see a nice example of a patient with an 8.3 millimeters squared GA. These are pretty big lesions. The majority of these lesions were multifocal. The majority of fellow eyes were involved. And as I mentioned, the majority of these were subfoveal in location, 2/3 of them subfoveal. Not listed here, but CNV in the fellow eye was not exclusionary. And so here we see the combined data from the phase 3 Oaks and Derby, and you can see reductions in GA growth, and you can see in the monthly group 20% of reductions at 2 years, and the every other month group 17%. And what's interesting is that as time goes on, you see 6 months blocks there. Each 6-month increment, we see increasing efficacy over time, which is very nice to see. You can break this down. I mentioned there's a difference between non-subfoveal and subfoveal. And you can look at the left here. You can see the non-subfoveal population, and you can see at 2 years, 26% reduction in the monthly group, 23% reduction in the every other month group. And looking at the subfoveal population, then on the right, you see those numbers are 18% and 16% for the monthly and every other month, respectively. Again, you can see that as you go on over time, the benefit increases. I'll point out that the benefit is also seen as early as 6 months, as is highlighted there in the panel. And so after Oaks and Derby, our journey continues on to Gale, and that's where we are currently. We've so far seen the data for 12 months from Gale, which amounts to 36 months in the trials for the given patient. And so Gale is an open-label extension trial. Patients were continued on the same regimen that received pegcetacoplan. Those patients in the sham group crossed over at 24 months into treatment. And they were in the same regimen that they would be on for sham. So sham monthly went to pegcetacoplan monthly. Sham every other month went to pegcetacoplan every other month. 92% retention rate in the first year of Gale is fantastic. And they looked at efficacy and safety in this trial. Interestingly, the sham group is now receiving pegcetacoplan, so we've lost our sham group to compare to. So in the 24 to 36 month data, we compared to a projected sham. And there's good data to support this methodology. From Janet Sinnes and others, we know that 2 years of growth, you can predict the next 2 years of growth. But we can also look at the rate of growth, which was linear in these patients. So you see the sham growing at 2 millimeters squared per year. The fellow eyes actually grow at the same rate, in fact, and you can superimpose these lines and see that growth rate is about 2 millimeters squared per year. So if we look at the results from GALE, we'll start with the non-subfoveal population. So this was just about 286 patients. Again, pegcetacoplan demonstrating efficacy at the end of 36 months, 26% reduction in the every other month group, 32% in the monthly group. But again, you see increasing efficacy over time, and the third year is quite impressive. In the non-subfoveal patients, there was 42% reduction compared to sham in the growth of the atrophy and 28% reduction in the every other month group. And so what does this mean for tissue? Well, obviously it means a preservation of retinal tissue over 36 months, as much as 2.44 millimeters squared preserved in the non-subfoveal patients, which translates into RPE cells saved, which translates into photoreceptors saved. And we'll talk more about what that means for functional endpoints. And so if we look at the overall population from GALE, including non-subfoveal and subfoveal patients, we can see again 20% reduction in the every other month group, 25% reduction in the monthly group, and again increasing benefit as time goes on. The safety events are of key interest, and we can see the safety events of OAKS and DERBY were very similar to that of GALE. I'll point out the rates of infectious endophthalmitis, 1 per 3,600. Intraocular inflammation was 0.26 per injection. We saw ischemic optic neuropathy. OAKS and DERBY, the rate was dose dependent. You saw 1.7% in the monthly group, 0.2% in the every other month group. In GALE, we saw one case of ischemic optic neuropathy in the monthly group. Exudative age-related macular degeneration was also dose dependent, 12% at the end of OAKS and DERBY in the monthly group, 7% in the every other month group compared to 3% of sham. And this trend continued on through GALE. To date, 215,000 injections have been administered and counting in the real-world setting in the clinical program, and there have been events reported of occlusive or non-occlusive retinitis or vasculitis. Fortunately, these are rare at a rate of 0.01% per injection. So let's talk about vision. This has been a controversial topic because the pre-specified vision endpoints were not met for OAKS and DERBY. And this has really been an evolution as we study and design these geographic atrophy trials, how best to look for differences when we look at our endpoints here. And so we'll talk about some ways that we've seen that there are differences in post hoc analysis. So here we have a Kaplan-Meier time to severe visual impairment defined as 2200, and we can see that pegcetacoplan delays progression to legal blindness with up to 38% risk reduction in the monthly group. We saw 12% risk reduction in the every other month group. Microperimetry may be the answer as to a good endpoint. And in fact, if we look back at a good old Chroma and Spectri, which is the lampalizumab trials, microperimetry showed the highest correlation with geographic atrophy area compared to other functional endpoints. And of course, microperimetry measures the patient-reported perception of light stimuli of variable intensity. This takes about 8.8 minutes. It was only done in OAKS and not DERBY. It's similar to a visual field test, but for macular sensitivity, and you can see it superimposed over the macular image. The junctional zone is an area that you can look for specifically because the mean sensitivity in that junctional zone is reduced to a greater extent in the perilesional junctional zone than in areas further away from the lesion. And we saw that also in Chroma and Spectri. And so in OAKS, the junctional zone of various sizes was evaluated. And you can see that pegcetacoplan had an effect on preserving those retinal cells. And you can see that because there is less worsening of the mean threshold sensitivity on the left in the total population, non-subfoveal and subfoveal, at 10% in the monthly and 12% in the every other month difference. And on the right, you see this non-subfoveal patients here where there's a larger difference, 18% in the monthly and 16% in the every other month group, and less formation of scotomatous points also. In addition to that junctional zone, you can also look at the central four macular loci. Okay, so increasing number of scotomatous loci in the fovea are associated with lower baseline visual acuity. So on this graph, you can see those patients that had 4 scotomatous loci had lower baseline vision. Those patients with 0 had higher. And so preservation of these central 4 loci appears to be clinically meaningful. And so if you look at the trial then, you saw that in this trial, patients with complete loss of central 4 loci lost the most vision, minus 11.7 letters on average. Those patients maintaining sensitivity in at least one of those foci lost minus 4.9 letters. It turns out that pegcetacoplan monthly had a 34% risk reduction over 2 years to progression of absolute scotoma of central 4 loci, 36% in the every other month group. You can also look at this in the central 16 macular loci, and very similar results. Patients with a complete loss of the central 16, minus 12.7 letters, and patients maintaining at least one of those loci, minus 6.3 letters. And again, pegcetacoplan had a 43% risk reduction over 2 years of the chance of developing an absolute scotoma in those central 16 loci in the monthly group, and 48% in the every other month group. In summary, we see meaningful reductions in geographic atrophy growth were observed in the pegcetacoplan-treated eyes, up to 42% in that non-subfoveal population at 36 months. We see increasing efficacy over time over the course of 36 months with as few as 6 injections per year. The safety profile of OAKS and DERBY is comparable to GALE, and to date, over 215,000 injections of pegcetacoplan have been given in the real world as well as the clinical trial programs. In particular, in the OAKS trial, we see the role of microperimetry as an important visual function endpoint in GA, and I suspect you'll see more microperimetry in upcoming GA trials. Thank you all for your attention.
Any questions?
So, Dilshar, great talk. I think the junctional zone is really interesting. Max Fowle has shown this targeted junctional zone assessment, because what's tricky, obviously, doing this post hoc is there's not that many spots, that actually end up in it. So you can have a really wide variation. I want to make sure I understood your slide around the central scotoma. So in that analysis, loss of having 4 scotomas, for example, you had significant lower vision compared to if you had at least one maintained.
Exactly, yeah.
And pegcetacoplan had a reduction in the number of patients who gained those 4 scotomas. Is that right? Or
if you were on pegcetacoplan, your odds of having 4 loci gone were less. So you reduced your odds.
Right.
Yeah.
So why does that not translate to the vision change?
It does. You mean in terms of the visual endpoints that were pre-specified?
Correct.
Yeah, it may over time. It's hard to say, but we also had patients in the trial that were fovea involving already, so it's hard to know. The population is skewed by that population.
Yeah. I mean, I think that's the real challenge. Is these weren't designed for visual function.
Yeah.
From the beginning, and then you're left searching for it.
Exactly. But yeah, I suspect that in future trials they'll probably look at this closer and be able to show this better. Yep. Thank you, guys.
Thank you. Next up, we have Arshad Kanani talking about avansicaptad pegol.
Thank you, Alec. Thank you, Kat, Kolai, for inviting me. Great job on your talk, Dilshar. So I'm talking about the second kid on the block is avansicaptad pegol. As you know, it got FDA approved in August of last year. My disclosures here, I led the steering committee for GATHER trials, as well as I'm a speaker for Iveric Bio. So what is avansicaptad pegol, or ACP? Is a small synthetic pegylated RNA aptamer that is designed to be a specific inhibitor of complement C5. So I'm not going to bore you with the complement pathway, just it's more of a downstream blocker. And what it is, a novel RNA aptamer with a unique branch, polyethylene glycol. And it blocks C5, which is more downstream, and that may have some benefit in the anti-inflammatory protection by preserving the upstream complement system. So ACP achieved the primary endpoint in 2 pivotal studies. The phase 2/3 GATHER study, we saw benefit early on that increased over time. And in the larger international GATHER 2 study, we also met the primary endpoint. And again, we saw benefit that increased over time. So looking at GATHER 2, which was an international study, randomized sham control, we had 448 patients randomized. In the first year, patients were treated with monthly ACP or sham. And at the end of first year, after the primary analysis, patients were re-randomized. So this is a very unique trial. It's not typical trial where you don't re-randomize patients, during the study, but patients were re-randomized. So patients who were treated were re-randomized to monthly or every other month. And the goal was to see if decreasing the treatment burden by every other month, if we are seeing any efficacy differences, are we seeing any safety differences. And then patients on sham were continued on sham. And then there's an extension study where every patient in this 2-year study is being treated, and that data will be available in the future. So what did we see in the GATHER2 study? So I showed you the benefit in first year. We see a benefit that starts early and then increases over time. Just as a reminder, even though you see those two lines, you have the lighter and the darker lines, every patient got monthly in the first year. And the second year, we separated it out to every month and every other month. So the purple line is every other month, and then the red line is every month. So we look at the p-value, they're significant for both every month and every other month dosing, and you can see that the difference is increasing as we treat more. Now, looking at the piecewise analysis, right, it's a chronic disease. Essentially, once you start in clinical practice, you are continuing these patients. We wanted to see if there's a benefit that increases over time. So if you look at every month or every other month ACP treatment, what you see is the increasing effect over time, which is good to see. That keeps you motivated to treat, because the longer you treat, the more benefit you get. The other question was, what is the efficacy in the first year compared to the second year? So as a reminder, again, first year, everybody was treated with monthly, re-randomized to every month or every other month. And what we saw was that the treatment effect versus sham was more than doubled with ACP every month or every other month over 2 years compared to the treatment effect over 1 year. So we are starting to see a benefit that's more than double with either monthly or every other month. Again, the patients were treated with monthly in the first year. So now let's look at some of the data. So GATHER1 was an 18-month study. GATHER2 obviously is a 24-month study. So we wanted to see the totality of the data at 18 months. And what we see here is, again, the pooled GATHER data. 18 months result demonstrate clear and meaningful effect of benefit, just like we saw in GATHER2 2 years. The effect starts early and it increases over time. And again, the same piecewise analysis, you see a treatment effect by 6 months, and then it increased through 18 months. The other thing is to look at the treatment effect every 6 months, again, which I showed you for 2 years, and you see almost twofold increase in the treatment effect with ACP versus sham every 6 months. So what we are seeing is we are seeing a benefit that's starting early, increasing every 6 months in both studies. Now, obviously, modest efficacy for complement inhibitors, so we need to make sure we pay attention to safety. So looking at the treatment emergent adverse events across GATHER1, 18 months, and then GATHER2, 2 years, I think one thing to keep in mind, in GATHER1, if a patient develops CNV, the patient was exited from the study. In GATHER2, we actually continued treatment with the complement inhibitor as well as an anti-VEGF on-label monthly ranibizumab or every other month aflibercept. So if you look at TEAE leading to study drug discontinuations, you see that most of those are actually non-ocular. So to ocular TEAEs, I think these are something we pay special attention to, things like choroidal neovascularization, visual acuity, endophthalmitis. So when you look at the data from 18 months of GATHER1, what you're seeing is that these are serious, right? So these are classified differently than just adverse events. You see that there is one ischemic optic neuropathy that happened between 12 and 18 months. And in GATHER2, when you look at that, you have one endophthalmitis, so 0.4%, and you have one patient with a subluxated intraocular lens, which was unrelated to the drug. Now, obviously, the real question is CNV, because we have seen increased rate of CNV with complement inhibition, and we wanted to compare that between GATHER1 and GATHER2. So when you look at the rate in GATHER1, 18 months, you have 11.9% versus 2.7%. And in GATHER2, you see 11.6% versus 9.0%. As a reminder, in this trial, fellow eye CNV was excluded. So looking at adverse event of special interest, right, a lot of conversation about inflammation, retinal vasculitis, because, we are all very sensitive to it. If you look at the data, you have one case of non-clinically significant vitreous cells in GATHER1, And in GATHER2, over 2 years, so a long period of time, you only had one case of, again, vitreous cells, no 0.4% intraocular inflammation. Looking at endophthalmitis, one case in GATHER2, over 2 years, 0 cases of retinal vasculitis, and I already covered the ischemic optic neuropathy. And both of those cases of IOI were non-serious and were reported as vitreous cells. So looking at GATHER2 monthly versus every other month, right? So we covered the totality of the data. Now let's look at, is there a safety difference between every month or every other month, which we have seen, for example, as Dilshir covered in pegcetacoplan. So we wanted to look at that. And here you see that the endophthalmitis obviously is injection related. It was cultured, obviously, and it was in the every month group. And then the subluxated intraocular lens was unrelated and also in the monthly group. But I think here is the important things to compare. So of course, intraocular pressure increase, these are 100 microliter injections, so we expect transient increase. And then all of these cases came down to normal the same day. So that's not a concern, but kind of expected. So we just need to make sure we monitor the perfusion of the nerve and make sure the patients can, see after the injection, otherwise intervene. Choroidal neovascularization, 7.3 in every month group versus 4.3 in every other month group. So there is a difference in CNV in the second year if you treat monthly versus every other month. And then if you look at the sham, the rate was 5.4%. So essentially, ACP every other month gave us comparable efficacy as monthly, while in the safety, we saw a CNV rate, which is actually comparable to sham. Intraocular inflammation was in the monthly group, and as I said, endophthalmitis was in the monthly group. So here are the key takeaways. ACP, 2 milligram monthly, and every other month reduced GA growth versus sham in GATHER2. Again, GATHER1 and GATHER2 both met the primary endpoint, leading to the approval. Treatment effect more than doubled over 2 years compared to 1 year for ACP 2 milligram versus sham in GATHER2. Robust efficacy was maintained in the post-hoc analysis of 18 months GATHER data regardless of dosing frequency. And we have seen a very well-tolerated safety profile. ACP was very well tolerated, both in every month and every other month. And the big difference for me personally was the CNV rate in the second year, every other month, was comparable to sham. Thank you very much for your attention.
Any questions to Arshad from the panel or the audience?
I hope that's a good thing.
So next up, we're going to hear from Bob Avery about how to treat patients with dry AMD. Thank you, Dr. Avery.
Thank you. Well, thank you again for inviting me to come and speak here. I know the coli doesn't use a lot of these drugs right now, and Dan and I sometimes argue about that. But let me try to give you my case for why I think it's a case selection argument. These are my disclosures. I don't have stock in either of these companies at present, but I did in the past. I won't belabor the fact that both of these drugs seem to work from a reduction in the RPE loss, and yet, as was mentioned by both of you guys, the visual acuity and different measures of it prospectively didn't seem to pan out in the course of the trial, but retroactively, post-hoc analyses have shown some visual benefit. What was not seen in either of these drugs trials, registration trials, was the vasculitis, occlusive vasculitis that sort of shocked us when we started using these drugs. This is one of the first cases which over a course of 2 to 3 weeks went to bare light perception and then eventually NLP and was enucleated. The REST committee has reported just at the end of the year on the cases up to about mid-October, and they had 14 eyes of 13 patients with this retinal vasculitis. These numbers now are probably on the order of 20 cases. 18 have been adjudicated, I'm told, by Apellis. It has occurred in both eyes, with both drugs, in 2 different eyes of this one patient with Stargardt's disease who received pegcetacoplan here in this eye and basically went LP about 9 days later. But 4 days after the first injection, the patient received the other drug, ACP, and developed a similar but milder case of occlusive retinal vasculitis. Fortunately, this eye recovered. The first eye was enucleated along with the case I showed before, and we've looked at the pathology of those two eyes. Hasn't been published yet. It's not quite ready, but it's interesting. It looks just like this only case of HORV that's been clinical pathologically presented following vancomycin. It looks the same as this in a lot of ways, with intense infiltration of the choroid, but no vascular inflammation in the retina. So it's a little bit of a surprise. When I first saw this paper, I didn't believe it. And it's funny, now we got two eyes with HORV from pegcetacoplan that look almost exactly like this. So it may be different from the type of retinal vasculitis, occlusive vasculitis that can be produced in monkeys here in this Novartis study of brolucizumab, how they were able to immunize monkeys to brolucizumab and produce a retinal vasculitis. And you can see in the bottom right corner a lot of inflammatory cells in the retina around the retinal vessels. We just didn't see this in any of the three eyes enucleated for HORV from different conditions. So there have been a lot of good opinions that have been published, including one from your Cole's famous leader, Dan here, expressing concern about using these drugs. And I respectfully agree with much of what's said. It isn't something that has a whopping benefit compared to the risks that we see, not just during the approval process, but these vasculitis cases, which can be devastating subsequently. But what do I look at when I decide to treat someone? I look at a variety of things that I think I can guess better what patient to treat than was just put in the trial. And you look at the vision, the location of the GA, which are related. Try to pick a patient that has a rapid progression, because if something's sitting there and not moving, it doesn't make sense to treat it. I look at the fellow eye status, the age of the patient, the treatment burden to the individual patient. And increasingly, I think we're going to be looking at AI as that develops. So just to briefly review some of the things we can look at that have an increased risk of progressing in these GI patients. Size matters. The bigger lesions progress faster than the small lesions. We learned that from AREDS, and we've learned that the GA progression towards the foveal center is slower than towards the periphery. We've learned that the fundus autofluorescence can sometimes predict the rate of progression, with these banded or diffuse trickling cases having a much more rapid progression than when there's no autofluorescence there. And even things like reticular pseudodrusen have been shown to increase the progression rate of geographic atrophy. So these are some of the factors I look at. But also from the clinical trial, we've learned, as mentioned by Dilsher, the subfoveal lesions, which were only in the pegcetacoplan trials, those just didn't do as well as the extrafoveal lesions. Not only did they not progress as fast, but they don't do as well. And so the treatment benefit for someone with a subfoveal lesion, first of all, you'd expect it to be worse because the vision's more impaired, but also it just doesn't progress as fast. So reasons to sort of not look in that direction for picking who to treat. One of these editorials about the concerns about using these drugs mentioned that it is exceedingly difficult to accurately predict the rate of progression in an individual patient. But I think that's in general true. But is it always true? I mean, what if I have 5 years of OCTs or history of the patient, or color photographs or fundus autofluorescence showing the rate? I think that the rate is somewhat linear in this sort of phase of progression, and you can get a clue from looking at an individual patient of how fast they've been growing over the past few years. This isn't possible when you first see a new patient, but that's where AI, I think, will help us in predicting the speed of progression of that individual patient. Here's a report from a company in Vienna that this is commercially available in Europe. This is a GA report, so they can take a single OCT and analyze the RPE loss, which is in blue here, and then the green is the photoreceptor loss, thinning of the photoreceptors, or EZ zone, the outer sag zone. And this ratio between the blue and the green, the ratio of the photoreceptor loss to the RPE loss, is very important for predicting not only the progression rate, but also the response rate to the therapy. Here's a time lapse of two eyes from the Oaks Derby trial from the sham arms. And you can see on the left, the blue had just a small ring of green around it, so just a little bit of photoreceptor loss. That's progressing very slowly. That's not a good patient to treat. That's not progressing fast. And here it is again. You can see on the on the right, you see the green. All the green is the photoreceptor damage and how fast over 2 years that is progressing. This difference you can tell on a single AI slide and a report, and you can predict which one's going to progress faster based on the large amount of green, shall we say, or photoreceptor damage. This was shown in the Philly trial, where you can see those blue boxes on the left are the increasing rate of progression based on the quartile of that ratio of the photoreceptor loss to the RPE loss. The green to the blue ratio tells you how fast it's going to progress, because the more green, the faster it progresses. But also, even in Philly, they could see some improvement, more improvement in the faster progressing ones. And on the right, you can see how the thickness of that EZ zone, the thickness of the photoreceptor, when it's very thin, those are the areas that progress the fastest in that meridian. So there's a lot going on that junctional zone right around the edge of the RPE loss. So this is when she shifted, Ursula in Vienna, shifted to looking at the Oaks and Derby. So this is a much bigger study here. And if you break all the people in the sham group into quartiles based on that ratio of the green to blue or the photoreceptor loss to RPE loss, the top line is the group with lots of lots of photoreceptor loss versus RPE loss. And the bottom line they're very similar. And you can see it breaks out very nicely. All 4 quartiles break out linearly how they progress, the speed with which the RPE changes occur over the course of the 2-year trial. And more importantly, as Justice showed this slide before, is the treatment benefit from Syfovre is very dependent on this ratio. The first quartile is, again, that one with not much photoreceptor loss around the GA. There was no benefit statistically of treating this patient monthly with Syfovre for 2 years. So it'd be nice to be able to identify that patient and not treat that patient. And this is where I think AI is going to really help us. Whereas on the bottom, the bottom right, the 4th quartile, there's a big difference early on in the loss of photoreceptors that you can predict now based upon the initial presentation of the amount of photoreceptor loss versus the RPE loss. So here's just an example of the study eye versus a fellow eye. This is obviously a best case scenario, but on the left, you see the fellow eye having the center involved with blue, which is loss of the GA spreading into the fovea with visual loss over the course of 2 years in the Derby trial. Whereas the study eye was treated, the one on the right, was treated and it doesn't progress into the center. Now, you can always cherry pick cases like this. I'm not saying this is typical, but this is just an example which seems to imply there's some benefit of treatment in this particular patient compared to his fellow eye. Again, you could cherry pick things like that. Justice has shown a similar thing that I find very exciting. He presented this in Hawaii, and I just want to show a little bit of his similar analysis looking at the photoreceptor loss, which is really the EZ zone loss versus a GA loss. And he shows the same thing, that the progression rate is higher of losing the EZ zone based on the quartiles again. And not only has he shown that, he's shown the response rate to ACP reduces this loss or attenuation of the ellipsoid zone. This is a patient, this is just the looking clinically. If I don't have AI, so this is, I look clinically for this loss of the EZ zone is demonstrated right here. And this is a patient from one of Carl's Will's residents that showed me this. And I think this would be a good patient to treat. I'll fast forward a little bit. After these visits are 6 months and a year apart, and there's pretty rapid progression. But what I look at is I try to see this EZ zone myself. And you can see near the fovea of this eye, a loss of the EZ zone that's clinically apparent to me. I think this would have a big ring of green surrounding the blue. If I had AI, I think this would be a good patient to treat. So anyway, if you do decide to treat, then what do? Which drug do you use? It depends on safety and efficacy. Do you treat monthly or every other month? I like every other month. I treat the weaker eye first. because the vasculitis is a first injection phenomenon. I wait a month after treating one eye before I treat the second eye the first time. And, I consider getting an Optos after the first injection to look for subtle vasculitis that I might miss. You can treat both eyes the same. If they develop wet disease, you can treat it the same day, but you have to tap them usually, and I don't like to do that. With respect to which drug to use, I think there's a hint that there's more efficacy with the pegcetacoplan based on this anchored study, but it's not perfect. You could also say, well, they didn't include GATHER1 for reasons that the CNV caused them to drop those patients, but GATHER1 had a better outcome than GATHER2. But there seems to be a hint that that might be better. On the other hand, there's a hint that the safety may be better on the ACP, where there's certainly a little less of the CNV that develops. Here you have like 2 times the CNV development in every other month and 3 times in every month. And as you could see, at least from the second year of the GATHER trial, it seemed to be fairly similar, not quite as much. In inflammation, you had maybe 4% for every month, 2% IOI in the Oaks and Derby trial, but you only had about 0.4% in the GATHER2 study. There was another case in the GATHER1 study, which didn't last the full 2 years. So in conclusion, this worrisome part about vasculitis may be the predominant reason we don't treat, or we treat less aggressively. And is there a difference between those 2 drugs? We just don't know. Neither drug saw it in their trials. But there have been, as Dilcher mentioned, 215 or so thousand vials shipped for pegcetacoplan, and ACP only about 50,000. So it's at least 4 or 5 times as many vials shipped. But then there are 20 cases reported for Syfovre and only 1 case reported for ACP thus far. We know it's underreported. People don't want to be sued. I think we're going to have trouble getting things reported the way we'd like. But anyway, finally, there are lots of other targets out there. Maybe this is a Macugen PDT treatment, but Peter Kaiser makes this list for Retina Today every year, and my gosh, there's over 30 complement inhibitors in some stage of development now, not to mention all the other things. So is this a cure we've been waiting for? Probably not, but it's all we have right now. And I think unlike the anti-VEGF treatments where anyone with fluid seems to benefit, here we have to really think about the patient and all the risk factors. It's a lot more art of medicine than just injecting anti-VEGF. And yet I think we can pick a patient with a good risk-benefit ratio, and at least until we get better treatments. So thank you. Sorry I went over a couple of minutes.
Any questions for Bob at the moment? We also have a panel on GA coming up. So maybe we'll move to Phoebe, who's going to give us a uveitis update before the GA panel.
Taking a break from GA before back to AMD.
Yeah, my goodness. Thank you for allowing me to infiltrate this retina meeting with the uveitis talk. So I'll be talking about current and emerging diagnostics and treatment. I'm going to skip over the imaging stuff. These are my financial disclosures. So this is kind of the pattern of uveitis that we see in a referral practice, such as at Coli. This was actually done at the Proctor Clinic, where a small percentage have infectious uveitis, medium percentage have known etiologies of non-infectious uveitis like sarcoid or birdshot, and then we have this 50% of non-infectious uveitis actually have idiopathic or undifferentiated uveitis, and we really want to shrink that piece of the pie that's at the 50%. So we need better diagnostics to classify uveitis. So the most common types of infectious uveitis that we see in the clinic are the herpes family viruses, HSV, VZV, CMV, also toxoplasmosis. And so, but the problem is we usually actually have to empirically treat them based on clinical examination, right, clinical findings, because when we test the PCR, for instance, with singleplex PCR, we have to send it out to another lab. It takes about a week to get the results back. So these 2 labs tested different ways of rapid multiplex PCR. In the left hand, Bispo and colleagues at Harvard used this real-time PCR followed by a melting curve analysis, looking at the 4 most common infectious organisms we see in uveitis, and they were able to get results at very high sensitivity and specificity compared to singleplex PCR for these four most common organisms in less than 2 hours. And then this other study did a case report, Ferreira and colleagues, where they took a corneal swab from a corneal ulcer patient and using a commercially available panel of
a nested multiplex PCR followed by melting curve analysis that was developed for meningoencephalitis as well as septicemia, like blood culture identification. And they were able to figure out that this patient had Pseudomonas corneal ulcer in less than 1.5 hours. So the commercially available test, though, is of course not been validated, in uveitis or in keratitis in larger studies. So what about metagenomic deep sequencing? So this is unbiased deep sequencing. Thuy Duan at UCSF has developed a unique method where they can detect RNA, DNA viruses, as well as parasites, fungi, anything that could potentially be causing the uveitis. And you can see in this example of a patient who has chronic bilateral uveitis that they were actually on immunosuppression. They actually had rubella. And so this is, even though this is a research investigation and it's not rapid, you can see how this can be very important in identifying novel pathogenic etiologies for uveitis. So this was a study by Lynn Hassman at WashU, which is looking really kind of in an unbiased approach at any type of uveitis and trying to see whether you can see patterns of molecular identification of uveitis using single-cell RNA sequencing. And what she found in this cohort of 4 granulomatous uveitis patients was that there were a lot of overlaps in terms of B and T cell clonotypes, as well as some unique features in these patients. So you can see, if this is a very small study, but you can see in a much larger longitudinal study using these techniques that potentially we can better classify uveitis and then also be able to figure out things like treatment response. So now moving on to treatment. And so this is kind of what you're probably expecting. I just had to deviate a little bit because everyone was going to talk about treatment. So current and emerging treatment for non-infectious uveitis. So we're going to go over some old, our tried and true treatments as well, because there's kind of newer ways of thinking about how we use treatment in uveitis, from local steroid injections to systemic steroid-sparing immunomodulation, as well as biologics, both local and systemic biologics. The tried and true fluocinolone surgical implant, there's still indications for its use. The MUST 7-year study showed that you get better and faster control, more complete and faster control of inflammation using the steroid implant. But by 7 years, when the implant has expired, of course, then systemic immunosuppression does a little better in terms of visual acuity. So the implant has its benefits, but that comes at the cost of glaucoma surgery and cataract surgery, of course. Those are pretty high rates of that. The dexamethasone implant, also now tried and true treatment for non-infectious uveitis, lasts about 3 to 4 months, was touted to last 6 months, and these are the rates of glaucoma and cataract. The POINT trial showed us how to compare periocular versus intravitreal steroids. We have to remember that both work, both routes work. Of course, the intravitreal routes seem to affect better central subfoveal thickness and best corrected visual acuity, but also increased rates of elevated intraocular pressure. So then the fluocinolone acetonide insert was developed, and it was also effective in terms of decreasing the probability of recurrence in non-infectious uveitis, and here are the rates of cataract and glaucoma. And then the suprachoroidal steroid injections were developed, and this underwent phase 3 trials with Peachtree, an extension study, and then open label study, and was FDA approved in 2021 for the treatment of uveitic macular edema, and these are the rates of cataract and glaucoma, which are not terribly high. So this is kind of to give an overview of this treatment ladder for non-infectious uveitis, starting from how we do steroid-sparing therapy systemically, from antimetabolites as first-line, second-line agents are usually the TNF-alpha inhibitors, and then third-line agents being biologics that target other inflammatory cytokines like interleukin-6 or B cells. But remember that it takes time for these to come on board, and so we have these times where you have to bridge them with steroids, and you can see as you go down the ladder that you really end up putting them on a lot of steroids. So that's when you start thinking, well, instead of using systemic steroids, are you going to use a local steroid instead? And when you're on that third line immunomodulatory agent, are you actually going to use a long-acting local steroid? And so there's actually the update here is not that a lot of these drugs are new. The update here is that we actually much more dynamically use local steroids with systemic immunomodulation in our uveitis patients this day and age. It's actually much more dynamic than it used to be. So tried and true but non-FDA approved off-label use of the first-line agents I mentioned was finally studied a little bit in this head-to-head trial, the FAST study, which looked at oral mycophenolate and oral methotrexate in uveitis and found that they were both effective, of course, but they didn't really look at sub-Q methotrexate, which has better bioavailability. In terms of the biologics, so they mostly target the inflammatory cytokines, with the most common biologic being the TNF-alpha inhibitors, adalimumab and infliximab, used for non-infectious uveitis. And of course, adalimumab was studied in Visual 1, 2, and 3, found to be very effective. And then it was also studied in JIA-associated uveitis in the Sycamore trial, along with methotrexate, also found to be very effective. And so this is really regular armamentarium for our pediatric uveitis patients now. Other TNF-alpha inhibitors, not studied as large studies, but there is evidence for patients who have refractory uveitis to other TNF-alpha inhibitors that they can actually respond to these other TNF-alpha inhibitors, like certolizumab was actually studied in a phase 4 study for uveitis associated with axial spondyloarthropathy. An emerging therapy that targets TNF-alpha is licaminlimab, which is, instead of being a full-length antibody, is an antibody fragment that targets TNF-alpha much more potently, as you can see here with the IC50s, compared to adalimumab and infliximab. And because of its small molecular weight, penetrates the ocular surface better, and thus potentially can be effective for treatment via eye drop. And so it's undergoing a phase 2 trial for dry eye disease, as well as being studied for uveitis. So what about targeting interleukin-6? This is a pleiotropic cytokine that's produced by many cell types and has effects such as promoting differentiation of Th17 cells. And a lot of biologics have been developed to target interleukin-6 as well as its receptor. Tocilizumab targets the IL-6 receptor and was shown in the STOP uveitis trial to be effective, but it seems to be especially effective for uveitic macular edema. And in fact, in this retrospective study by the French Uveitis Network, where they compared tocilizumab with TNF-alpha inhibitors, Toci was actually found to be more effective in complete control of uveitic macular edema than TNF-alpha inhibitors. But this also, they didn't actually show a difference in terms of steroid sparing or relapse rate. An emerging therapy targeting interleukin-6 is called vamikibart, which is designed for intravitreal use. So this particular antibody, the FC region, was designed for fast systemic clearance and minimize potential systemic adverse events. The T1/2 for intravitreal dosing was approximated to be 7 days, which is similar to faricimab. And then the mechanism is that it binds to interleukin-6 itself and prevents both cis and trans signaling through the interleukin-6 receptor. So the results of the phase 1 uveitic macular edema trial for vamikibart showed that in patients who received any dose of the vamikibart showed best corrected visual acuity improvements, as well as reduced central subfoveal thickness, and was well tolerated. And that's why it was fast-tracked actually for phase 3 studies, which are ongoing now. The JAK-STAT inhibitors, so this is downstream of the cytokine receptors. These are advantageous to be blocked because they can be developed as small molecule inhibitors and taken orally. So here are various JAK-STAT inhibitors. One of them actually was halted. The study for the Humboldt trial for non-infectious uveitis was halted due to testicular toxicity. Baricitinib is a JAK1/2 inhibitor that is undergoing clinical trial for JIA-associated uveitis. And an emerging therapy is dual TYK2 and JAK1 inhibition with an agent called brepocitinib. And you can see how this could potentially have a wider effect because it targets really more cytokine pathways, and it's undergoing a phase 2 trial for the treatment of active non-infectious uveitis. So the summary here is that there's a need for more rapid and specific detection of infectious uveitis, that there might be a role for molecular classification of uveitis, that short and long-acting steroid implants are very useful in treating non-infectious uveitis and are increasingly utilized to spare systemic steroid requirement, as well as bridge efficacy of IMT. And then there are many options for steroid-sparing therapy, biologics, and IMT, but additional local and systemic biologic development is needed. Thank you so much.
I like, Phoebe, how you assumed there would be no questions.
I just think that was a mic drop right there. I was, so I'm when you see all those words out there, all it does is it makes it more secure for those of us who do retina and uveitis. We don't have to worry about most people really wanting to follow all of that. This scares a lot of retina people. That's what I'm trying to say. So anyway, but actually, I love it. It's cool stuff. So, all right. So we have supposedly 20 minutes, but I'm going to not take 20 minutes. Okay.
Famous last words, Dan. Famous last
You watch.
words.
You watch. Okay. All right. So, case one: 80-year-old woman followed for dry AMD, presents with new onset vision loss. Oh, by the way, I should say, the first draft of these slides Sunil did for me. So there are the requisite making fun of me slides in here, and I left them in. So, but I got them back. You'll see. So, we have a lot of fun on the Retina service at Cole. All right, 80-year-old woman who's followed for dry AMD presents with new onset vision loss in her right eye, pseudophakic glaucoma. So she's 2150. And in the right eye, in the involved eye, 20/30 is in the left, normal, slit lamps, unremarkable except for some pigment that's been seen for a while on the endothelium. So this is what her OCT looked like 6 months before. And this is what it looks like now. So who wants to go first? Sumit, I'll start with you.
So she's gotten a large serous PED with some subretinal fluid on the edges, and you can see some material inside of it. It's not completely serous PED because you can see some material inside of it, and it's presumably developing a CNV.
Yeah.
That's what you're seeing so far.
So what's next step?
So it used to be you'd get an FA and you talk about, is this, what kind of lesion is this? But we don't do any of that anymore. So you could, if you really wanted to, you could get an OCTA, but most likely you're just going to inject them with anti-VEGF at this point.
Would anyone not treat that?
I think with the vision loss, I would,
Yeah.
you know, but I would also talk about possible RPE rip. This is an acute onset. The PED is quite large, and you know, these PEDs can rip even without treatment. But you give a treatment, and they have a rip. There's a connection immediately, so that was due to your treatment. So I do have that discussion.
And, you know, in addition to the vision loss, you have the change too. You know, if somebody walked in the door with that and still had, you know, good vision and you had no historical, maybe you'd watch it a little bit. And unfortunately now the other thing you have to get is pre-authorization.
Right. So in terms of choosing your drug, do you think one drug might work better for PEDs? There's been some presentations about that as of late.
I think some of the newer generation agents, like Firsimab, like works really well at getting rid of PEDs. My one concern here would be, you know, is the drug going to work too well at getting rid of that PED? But to be honest, you can get RPE rips with anything, so I would just counsel appropriately.
Okay, so this patient started with bevacizumab, and basically the question is, I guess, so what's your endpoint with these large PEDs? You'd like to see it totally flat, right? And so if you treat for a little while and there's no change, what's your criteria to switch? The visual acuity here is better at 20/40, but after you've done this 4 times, there's still a substantial PED there. And there was subretinal fluid, which it went away after the first injection, it's returned. And there was the OCT prior to this one, there was subretinal fluid. You're treating about every 4 to 5 weeks. The vision's 20/50. So at what point would you switch? Would you switch after 1 injection, 3 injections? How long do you go?
I think 3 would be good. I think, Dan, I'm not chasing the PED, I'm chasing the fluid.
Yep.
And
me too.
PED improvement is a bonus.
Yep.
For me.
That's really well said. Okay, so she was pre-started for aflibercept the last visit, and so she gets aflibercept today, follow-up 4 weeks later, and surprisingly it's 20/80, and there's no AC cell, but there is the pigmented KP on the slit lamp was noted by the fellow. So, what do you think? Worse, stable? I'd say about the same.
Worse.
Maybe worse, right? Okay, so what's most surprising? They give a single aflibercept injection. What's most surprising? Is it A, there's non-response, B, possible inflammation with the aflibercept? I don't think so. C, the fellow actually looked with the slit lamp.
All of the above.
Yeah, that's right. So should you switch again? You've given 1 injection. How far would you go with this?
Well, it doesn't, I mean, if there's a hint of inflammation and we have other drugs, I would switch to Vabysmo.
Right. So this is not my case, by the way. So went to back to bevacizumab, and the fluid went away, but eventually the fluid comes back, and yeah, you're annoyed. So this is what this whole case is really designed, was to get to this point. So the switch to faricimab. So I'm going to tell you it works. How many shots do you think it takes to make the PED go away?
One.
So I've had that experience too, and that's not what happens here. Okay. Turns out it's 4, but it goes away. But it does go away, and they're shown in reverse order. Sorry, backwards.
Yeah, I was gonna say.
Yeah, sorry. No, sorry.
Making it worse.
Sunil made this slide. I'm not mine. Okay, so but it did get better. It took 4. So the message is, yes, we've all, some of the newer agents may be more effective in this setting, and I too have seen that. I too am sort of attempted to use these drugs much earlier in this setting, and but to not be discouraged if it just doesn't go away with
And
one.
Dan, we actually saw that, right? When we looked at the subgroup analysis of Tenai and Lucerne,
Yeah.
that faricimab really outperformed aflibercept 2 milligrams in terms of PD rapid reductions, and the percents that had persistent PDs were markedly lower in that group versus the aflibercept.
Excellent.
So I've also seen in the Harbor study with the 2 milligram ranibizumab over 0.5, it had a better effect on the PEDs.
So
So
Jenny,
it may be a dose thing as well.
So Dan, Truckee showed the same thing. So this falls into the Truckee subgroup, right? It's a previously treated patient. So
Yeah.
Tenai and Lucerne were naive. They show that, and then Truckee, and I think it's just that the one injection does most of the resolution. And Nishant Notel, and we have a paper coming out in terms of fluid, in nanoliters pretty soon, and that shows the rapid improvement in anatomy. So my question, why is Cleveland Clinic using bevacizumab? I mean, if it's a whole can of worms, right? But is it an insurance issue, or is it because of CAT and bevacizumab works well, or
this is my patient. I don't know why.
Okay.
I actually.
We'll blame Sunil for it.
I mean, I'm not dodging the issue. I actually probably wouldn't have used bevacizumab here.
Okay.
I mean, there are a lot of payers now who are mandating.
Oh,
to
yeah,
start
step
with
therapy,
it.
yeah.
I mean, and we're seeing it more and more. So even as, there's no actual Cleveland Clinic mandate
No,
around
there's
it
not.
at all. But I mean, all of the Medicare Advantage,
Oh, it's terrible. We are seeing
it's
a
so
huge,
challenging.
huge.
Yeah,
step
just and to
therapy
repeat
on
what Justice said, we don't ever. I've never told anyone ever what to do at the clinic ever.
Except
so
him.
yeah. So reminder. Well, what's that?
Nothing.
No. I missed it. It was funny, I think. So I don't want to hear it. Okay.
So
And then-
has anyone seen the PEDs come back as you extend them on Vabysmo? I've had a couple patients where that's happened. As you go a little longer, all of a sudden the PED starts growing again, but no fluid.
I think it's a dose thing. I think the PEDs need a
Yeah.
higher dose.
And it makes me nervous around the risk for RIP as you see that dynamic process as well.
Okay, and this is just a reminder that PED resolution can really happen with any drug, and here it is with bevacizumab. Oh shoot, what happened there? Oh no, did I not call this? I swear to God, the last one shows it's completely gone. Okay, you have to believe me. I deleted one by
We
accident.
trust you, Dan.
So no, it really did,
Trust
and I've seen it go away with one.
Went
It can
away.
happen with all, but I
Sounds-
do
looks like
think
sabotage.
I think that when you look at the composite
Yeah.
data, is what everyone has sort of referenced.
There it is.
There was.
I saw it.
Oh, there you go. Okay. All right. I don't know what happened there. Okay, 75-year-old. She has AMD and drusen, left eye. She comes in with changes to her right eye, 2100. And that's what she looks like. There's the right eye versus the left. Here's the right eye compared to 6 years ago, whatever you want to see it. So you want to do any other testing? Is that enough? You got an OCT?
Yes,
Yeah.
that's enough.
Almost has a bit of a bacillary.
Yeah, so here's Sunil's slide. So this is, that references that I'm old is what that's about, okay? And by the way, I'm not a boomer. So. Just that you know.
What was before the boomers? The greatest generation?
No, thank you very much. I appreciate that, Babier. That's right. I was 4 years old when the Beatles hit, okay? I was 8 when the Summer of Love happened,
I
so
know.
no. Anyway, so treatment of choice. Which anti-VEGF would you use for this PED? And are you concerned about risk of RIP? Alexander brought that up, and I agree. Should I just start with faricimab?
Depends on insurance.
Yeah.
Let's say insurance isn't an issue.
Sure.
Faricimab.
You could start.
I'm not sure that it matters.
Yeah.
I mean, I think that you can, a lot of these have such a high response that I think either aflibercept or faricimab, you could easily see a fantastic response with it.
Yep. So started with faricimab and comes back count fingers.
Nice rip.
Ooh.
Yeah, it's a good looking rip. So is this a function of the drug or the disease? And I think we've already said this, that you can see rips with anything, any drug you choose. We saw it in cat with bevacizumab, right? And with anything, and here's a shameless plug for Sunil, he published a paper with PDT. And what I particularly enjoyed the most about this slide, look at the very bottom of it. It says buy. He's got a side hustle going on, trying to sell his old papers, right? Because I don't pay him enough money. So, all right. Let's see. 77-year-old female with AMD, glaucoma, new onset vision loss, poor vision in the left eye. You know what? What time is it? I don't want to do this one. Okay. There's a dense
Spicy, Dan.
There's a dense vitreous hemorrhage, and there's a vitrectomy here, and we clean it out, and we do some anti-VEGF injections. Do pretty well. Okay, let's get to this. It's more fun. Okay, so for the next images, let's assume that you've accepted the role of current GA treatment and you use the medication. Some patients, by the way, I agree with everything Bob said. We don't use. No, I mean, there's no black and white here, really. It's the. There are subgroups here that do seem, it makes sense. I get really nervous about doing too much with post-hoc subgroup analyses because there's always uncontrolled confounding, even when it's mostly driven by the anatomy. I can still show you examples where that goes awry. But nonetheless, the cumulative data, the composite data suggests that there's probably something here. Problem is I don't have AI right now, and I don't know how to select these patients, which is why we don't use much of these drugs. But let's just assume that because in fact, that argument even reinforces why I have too many patients who their GA didn't change for 3 years, 4 years, and I would have been treating them the whole time. So the drugs clearly do something. I think that I buy into that, and I just don't know how to select who benefits in this and who doesn't. And indiscriminate use across all GA is for me problematic. So for the next images, let's assume you've accepted the role of current GA treatment and you use the medication in some patients. So would you offer treatment in either eye? So I'm going to show you a series of cases here. So here's one. I'm not going to give you much information. 20/70 count fingers. Just purely on the basis of the anatomy, what you see. Yes, no?
So, I think it's always hard with these en face images because the en face images it's like a poor man's fundus autofluorescence image. But it's really not because there are lesions that are beyond the expanse of that area. So, if anything, you're going to treat the right eye in this patient. And the question is really how much of the fovea is involved. It does look like it is involved, even though, because it's just so hard with the transillumination changes there. So I do think it's involved. I probably would treat the right eye and talk about the risks and discuss all the conversions and issues with it and give at least the option.
Okay.
When I look at that, the one thing that's interesting is the left eye almost looks like it has a disciform scar there combined with atrophy. And the right eye, I'm trying to understand why they're 20/70 because they're, subfoveal EZ actually
EZ
looks
is
really
good.
Yeah, looks great.
So I actually get really concerned they have horrible glaucoma because you don't see much nerve fiber layer there. So if I'm going to inject 0.1 into that eye of either of those drugs, I'm pretty nervous about that.
So how about this one?
Is this a glaucoma one as well? is this the theme of the AMD panel? AMD glaucoma.
Okay, how about this one?
I think this is where having more images than just one snapshot
Yeah.
would be like super helpful. For
I'm just going to tell you,
hard
it's a little unfair what I'm doing right now. I know. You'll see in a minute.
These are not.
No, it's this here. Yeah.
How about this one?
These are not AMD.
How about this one? or this one? So the reason I'm showing you all these, let's go back and review these cases. Here's case number 1. Here's case number 2. They're both late onset retinal degeneration. They're not GA. And there's the genetic lesion. Number 3 is not GA. It's pattern dystrophy, a PRPH2. Number 4 is an ABCA 4 Stargardt's. Number 5 is MID, mitochondrial inherited disease and deafness, diabetes and deafness. Number 6 is another case of ABCA 4 Stargardt's. So the reason I put these in here is because these drugs are not atrophy drugs. And we in the retina community, the non-thinking ones, treat them as such, and that's wrong. These drugs were designed to treat a very specific disease with a very specific anatomy, with a very specific, reasoned out reasons why blocking complement. But you have no idea whatsoever that treating a patient with Stargardt's or treating a patient with any other disease, that these drugs will do anything. You have exactly zero data. And I'll close with kind of this. So this is out of cat. This is a patient at baseline, newly diagnosed neovascular AMD, and here they are at 104 weeks. So as you can see, there's some GA, some macular atrophy that's beginning to evolve. And the point I want to make is that not only do we not have any data to suggest, I'll say it again, these drugs may have a role in geographic atrophy. Clearly there's some efficacy. But that's all you know. They have zero role, as far as we know, in any other cause of atrophy. And that includes the atrophy that may evolve in the development of neovascular AMD. So macular atrophy is an important contributor to that vision loss. And we've seen it in lots of studies. It's probably one of the major reasons why we see at year two versus 5, why the visual acuities decline. A lot of it is evolving atrophy. In CAT, 80% of the atrophy occurred in the bed of the original neovascular membrane. So think about how different this scenario is versus the disease we're trying to treat and the disease in which these drugs were studied. Atrophy developed in the presence of macular neovascularization. I put likely to be kind. It's totally different than the atrophy that occurs in the absence of macular neovascularization. Look at the difference of what's in the subretinal space. In the left eye, you have neovascular tissue, you have different cytokines. Why on earth do you think blocking complement in that setting is going to result in any benefit? And where's your data? Both pegcetacoplan and aficamten were FDA approved for use in eyes with geographic atrophy without macular neovascularization. There's exactly zero data that suggests either of these drugs have an effect on atrophy in eyes treated with macular neovascularization. If I had a nickel for every patient who comes into my office who is coming in for a second opinion, who has been treated for 2 or 3 years with for their neovascular AMD and now has evolving atrophy, and now they're getting one of these two drugs. It comes up all the time. Look, we love to do stuff we have no data. We're really good at it, and that worked out well with bevacizumab, intravitreal steroids, and others because there was an immediate therapeutic effect that could be observed in OCT and or vision. You can see an effect on vision when it worked, and therefore there was an obvious stopping point if it didn't. And that's the problem. There's never an observable effect with pegcetacoplan or aficamten, and therefore there's no indication of when to stop. So your choice to start a patient 2 years into their treatment of the neovascular AMD who then begins to develop atrophy at the same time, I see how we can rationalize that. We can say, oh, that's the background dry AMD progressing. But you have totally different anatomy happening in the subretinal space that was not present at any of these trials. And it is an incredible breach of logic to assume that the two are the same and that the effect therefore is the same. So, if you use these drugs, great. But the only thing I stand firm on is neither of these drugs should be used for evolving atrophy in eyes with neovascular AMD until there's clinical trial data that shows whether or not there's a benefit. And the same sort of applies to the case that Bob showed, the patient who had bilateral intravitreal injections, one with and had the left eye nucleated from following the Syfovre injection, and then developed a hemorrhagic retinal vasculitis severe in the right eye. Didn't have GA. Had an inherited retinal disease with some atrophy. Assuming that this drug's going to work in that setting, I mean, God, I hope they do. I would love it if they did, but we don't have any data. And you don't know then once you start when to stop, and that's the problem. Okay, that's my closing comment. Any comments you want to make? Yep.
Yeah, quick question, Dan. So in the clinical trials like the GATHER program, MOOCs and Derby, what proportion of patients do you think had these GA masquerades? I mean, how are they differentiating in the trial? Because I mean, here you have a panel of us. A lot of us felt this was AMD, right? We were all fooled.
I don't know. I don't know. And most of what we see is probably not that. It's probably not those cases, but those were. But some of that's out there. You just got to be careful. That's really the message. As part of our responsibility to our patients, we have to be careful not to overtreat and certainly not to treat in settings where we don't have data to guide that. I'll say it again. It worked out fantastically well with anti-VEGF because there was an immediate therapeutic effect. We injected, we could see something on the OCT, the vision got better, the patient's happy. But that's not what's happening here. You're going to start injecting into the patient. The only benefit the patient has to trust that they're going to follow the composite data, that they're going to fit what happened to the whole group of people. And the problem is that in these settings, you don't have a whole group of people's data to sort of guide that. You have zero data.
Dan, I was going to comment, I agree with you about these. We don't, at least I don't treat, patients with macular atrophy from CNV because it's not in the study, and I don't treat Stargardt's, but I collect those eyes when they have the treatment.
Yeah.
No.
Yeah. Okay. On that happy note, again, thank you for being here, and you two have been wonderful. So go ahead, and Alexandra and Kat, if y'all want to close it out.
Yeah. So thank you so much to all of you for joining us, for your attention and participation. You really make this course. And of course, thank you to our wonderful, wonderful panelists. I think yes. The quality of the presentation and discussion has been so fantastic. I learn every time. This is a way to claim your credit. And also, I already got an email about an evaluation, so I'm sure all of you have as well. And thank you so much for joining. We do this every year before ARVO, and we also do Coli Imaging Summit before ASRS that is run by, I think, Sumit and Justice and Sunil. So please join us for that as well. And for faculty, please stick around because we would love to get a lovely picture with all of you. Thank you, everybody.